one Egypt, number two. We have 10 speakers from 4 countries, Egypt, India, UK, and from the USA. So we will start by our dear professor, Professor Osama Shazli, professor of orthopedic surgery and foot and ankle surgery and Shams University, and the president of the Egyptian Foot and Ankle Association. Professor Osama, thank you so much for being with us, sir.
Thank you, Dr. Muhammad. Do you hear me or في مشكلة?
Yes, sir. We can hear you, sir. We can hear you.
Okay.
Thank you so much, Dr. Muhammad, for inviting me to share in this fantastic and valuable course and session. We always use to your wonderful preparations and wonderful collection and gathering of eminent names in every subspecialty. So thank you so much for being one of your members or faculties of your course. I'm happy to be with other faculties. We will talk about complex malunited ankle fractures. I will try to make it case discussion, and I wish all participants to participate with answering in the chat box. So please, this is an interactive session. So all participants, please, when I ask you, I hope you will respond to chat box, okay? Here we are going to identify some pitfalls in management of malleolar fractures. Doctor, yes, please, Dr. Hisham, to be silent. Dr. Hisham.
Dr. Shampi, may I ask you to mute yourself, please?
Yeah. So here we will identify some of the pitfalls in management of malleolar fractures. We will try to outline the treatment options of these malunited fractures and apply some tips and tricks for proper surgical management of malunited fractures. Let's start with this case. She is 52 years old lady. She fell downstairs. She had ankle fracture, no medical conditions, and she was transferred urgently to ER. So back slap was done for the patient. CT scan was done and showed this fracture. So my question to our valuable participants, what would you do for this case? It's trimalleolar fracture. I show you the X-ray again. Can you answer in chat box? Yeah. No response yet? Are they allowed, Dr. Muhammad, to answer in chat box or not allowed? Hello? Dr. Muhammad Al-Ashar?
Yes, Dr. Osama, they are allowed to chatting.
Yeah.
They are allowed to chat with us.
Okay, now they are allowed. So now what do you see here? We have trimalleolar fracture, posterior malleolus, lateral malleolus, and medial malleolus fracture. So what are you going to do for such case? Okay, this is what has been done. At day 10, after improvement of soft tissue condition, ORIF was done for the lateral malleolus biplate, and the patient had fixation for the posterior malleolus, and syndesmotic screw was applied for the patient. So my question, any comments on this reduction and fixation? Okay. Ammar, Wahban, and other, can you? Yes, there is medial clear space. It's okay. It's mal-reduced. Possibly the syndesmosis is not reduced well. Okay. So if you have the patient in this stage, what are you going to do? Who will go for revision of this case? Revision. Muhammad Khalaf say we have to do revision. Very good. Mahmoud Darwish will revise. Okay, that's good. So most of you answer we will redo for the patient because we have media clear space open. Almost the syndesmosis is not well reduced. We don't know about the length of the fibula. So you think about revision. Unfortunately, our surgeon decided to continue on conservative management for this patient. The patient start with pairing and start to have pain. And here is the X-ray of the patient after 3 months. Now, anyone would like to comment about this case, these 3 months? We have here, what's your comment about the media clear space? Yes, it is open. Okay. What about the fibular length? Yeah. We have here shortened fibula. If we make the dime sign, we will find shortened fibula. What about the syndesmosis? Okay, there is stellar tilt and there is most probably open syndesmosis, right, Dr. Ayman? So in this case, what's your further management? What we are going to do for this patient? Who will go for revision of this case? And who will go for primary fusion of this case? We are 3 months after trauma and the patient start with pairing and she still has pain. So what should we do? Revision. Muhammad Wahid, revision. Do you all agree for revision or would you like to go for primary fusion? Said Abdullah say we make total ankle arthroplasty. I think this is, yes, big surgery for 45 years old lady. She is active patient. So we have majority of you said we have to do revision and some say we have to do primary fusion. And of course, the surgeon suggested for hair implant removal to improve pain, which is not valid for this case. So I think you agree that we need to make planning for revision. This is the pre-operative examination of the patient and assessment. She has good alignment. She has some limitation in movement on the right side, but she still have good range. She has pain with walking. So the preservative surgery or conservative surgery of this malunited ankle should be considered rather than making primary arthrodesis. This is a radiological evaluation of the patient, making standing views comparative with the other side. We can see the shortened fibula, widening of the medial clear space, the syndesmosis is still open. CT scan preoperatively confirm the same diagnosis for the patient. So we decided for this patient removal of the implants, we make fibular lengthening and reduction of syndesmosis. So how can we make lengthening, this is after removal, how can we make lengthening of the fibula? I show you the X-ray. After removal of implant, what kind of osteotomy you prefer, Abdullah, to lengthen the fibula for this patient? Who will choose doing oblique osteotomy? Good. Okay. Who will do supramalleolar, suprasyndesmotic osteotomy with lengthening? No one. Any one of you knows another kind of osteotomy rather than oblique osteotomy or suprasyndesmotic osteotomy? Z osteotomy. Thank you, Dr. Am. Yes, Z osteotomy or Z plasty, we can do it. So we have different options to make osteotomy for this patient. This is a technique how we make for the patient removal of implant, and we expose the syndesmosis and clean any soft tissue inside. And then we fix plate, anatomical plate distally in this way. And then we make for the patient. Here is a syndesmosis, how it's open. And then we go for oblique osteotomy for the patient. The value of oblique osteotomy, when you do it, you don't need to disrupt the syndesmosis. So you can restore the length of the fibula without disruption of syndesmosis. We plan the site of osteotomy. We do it in this way. And then we make distraction using
this way. 1, 2, 3.
this laminar spreader. And then we fix the fibular plate again, and we close the osteotomy. Then we reduce the syndesmotic joint, and we do it with a clamp, like you see now, and then we put syndesmotic screw. And this is the restoration of the length of the fibula. Here is the post-operative standing views for the patient. Here is a CT scan post-operatively for the patient. And here is the range of motion of the patient. The patient regained full range of motion and she is walking pain-free. So this is the first case. Let's go to the second case of malunited ankle fracture. This lady is doctor, she is a physician, and she got this, she was 28 years old. She got this injury, twisting injury to the ankle. She had trimalleolar fracture ankle, as you see. She had extensive swelling and edema in the ankle. So patient was transferred to OR, and she was in one of the countryside hospitals away from the capital, and she was operated due to bad soft tissue condition with such fixation. What do you think about this? It's unstable. Yes, the patient has such mal-reduced ankle, shortened fibula. The median malleus is not properly reduced, open syndesmosis. The ankle was unstable. See, he put such K-wire. Okay, so we all agree that trimalleolar fracture ankle is unstable ankle fracture. It should be treated with rigid reduction, absolute reduction, anatomical reduction, and rigid fixation. So this is what happened, and the patient coming to you with this second day post-operative. What are you going to do? Of course, revision. Okay, but the surgeon told her, we will wait, it may unite, and he kept her for 6 weeks. And after 6 weeks, he made removal of the K-wire transversing the ankle. And now this is the situation, 6 weeks after. So what should we do after 6 weeks? Revise, very good. But the surgeon decided to keep her for a while. He said it may unite. And he kept for 4 months post-operative and asked her to go for physiotherapy. Look at how she is walking with fixed almost ankle, with painful antalgic gait. And she has what you are seeing now, shortened fibula, talar tilt, and non-united medial malleus and open. The age of the patient is 28 years old, and she is a physician, she is a doctor. So what are you going to do for this patient after 4 months? Okay, revision. Abdul Rahman say, long time of non-wood bearing. Would you like to continue conservative, Abdul Rahman? Yes, Abdul Rahman? No, okay. So what should we do? Who will go for revision? And who will go for primary fusion, for fusion of this case? Revision. Majority of you say we need to go to revision. Okay, this is what I told the patient. We made for her CT scan to check for in union, but actually the screw in the fibula was outside the fracture side. The same was for the medial malleus. So we planned for implant removal, fibular lengthening, and fixation of medial malleus and bone graft. And here is after removal of the plate, look at the fracture site here. And then we did for the patient also exposure, removal of blunt medially, and the median malleolus is also malunited, as you see here, with some of bone defect is present. And then we made osteotomy at the same fracture site before, as you see here. And then we made also refreshment of the median malleolus fracture, as you see here. And then we start revision of our fixation. We did the same principles of lengthening of the fibula through this oblique osteotomy, and we made distraction with anatomical plate, reduction of the fracture once more, and this is the intraoperative image photos for the patient after reduction of medial malleolus and reduction of the fibula. We restored the length of the fibula. Then we went for the syndesmosis. We made testing for instability of syndesmosis, and then we fixed the syndesmosis with syndesmotic screw. This is 10 weeks post-operative. The patient is walking much more nicely, and the X-ray looks nice for the patient. And then we went for physiotherapy, and the patient had marked improvement in range. He was able later to sit on the ground and to pray in this way, and continued physiotherapy for several months later. And here is the final appearance of the foot of the patient. It was nicely. Dr. Rajiv say I would use 2 syndesmotic screws. Yeah, I agree with you, but I thought it was enough and it was properly reduced with 1 syndesmotic screw. Also, I didn't have a room for that. I don't need, Dr. Amr Farouk asks, do I need for oblique osteotomy? Do I need a graft for oblique osteotomy? Usually, I don't need for oblique osteotomy grafting. If I make oblique osteotomy, you can reduce it without grafting. Yeah. Well, and this is the range of motion of the patient after full reduction of the case. Let's move to the third case here. This is 42 years old lady. She fell from chair and she had this pilon fracture due to axial loading. CT scan was done for the patient and it confirmed that the patient have pilon fracture fibula, and the patient was transferred to the hospital for receiving treatment. It was also countryside away from the capital hospital. So what is the treatment option for this case? Who will go for open reduction internal fixation? It's closed injury. Soft tissue initially was bad, but it improved after 10 days. It's low energy trauma, and she fall from a chair. Who will go for external fixation for this case? Spanning is okay. Who will go for primary arthrodesis for this case? I think no one. So Ayman and most of you say we will go for open reduction internal fixation, or you can span if the soft tissue condition is bad and you go. This is, yes, I agree with all what you say. But unfortunately, when she went there, she received this kind of fixation. So what do you think about this kind of fixation? He fixes the fibula and fixes the medial malleolus. He lifts the anterior part and he treated it as if this is Potts fracture ankle and not Pilon fracture ankle. Yes, Dr. Amr, this is not Potts fracture ankle, it's Pilon fracture. So the patient didn't receive anterior plating, not reduction of the fracture. Still, there is some subluxation inside. And the patient was left in cast for a while, around 4 months in cast. And the patient came to me with this fixed equinus anterior translation of talus. And we have this almost united anterior part of the tibia and medial malleolus and fully united lateral malleolus. So what are you going to do? Revision. This is 4 months, Pilon fracture. Who will go for revision? Okay. We will go for fusion. Do you want any additional imaging or something like that before you decide arthrodesis first? Yes, CT scan. Mustafa has 4. Say we need CT scan. This is a CT scan, Mustafa. So what do you see in the CT scan now? The syndesmotic screw is out. There is partial affection in the lateral part of the talus. We have partially united anterior part of the tibia, distal tibia. So we have all of these stuff. So what would you do next? Who will go for arthrodesis after CT scan, and who will do joint preservation surgery? Revision. Sharif al-Naggar. Okay. Joint preservation. Muhammad Asfour fusion. Joint preservation. Yeah. So I think this case, it's more debatable than the previous ones. The previous one, most of you said revision, but here we can think in fusion because this is Pilon fracture, a convoluted intra-articular, it's neglected for 4 months. Maybe fusion be a good option. So the patient is 48 years old. So I decided with the patient, I discussed that with the patient, we will make for you a trial of revision, and it's possible to make revision for this case, but you may have evolving osteoarthritis later, and it should be in consideration. Rajiv, you ask about ankle replacement. Really, I'm not experienced with ankle arthroplasty in such case, post-traumatic case with such much. I don't know if any other of the faculty, Dr. Hisham or any other, would think about ankle arthroplasty in such case. What do you think, Dr. Hisham? You can open the speaker. And Dr. Rajiv, if you want to say something, please unmute yourself and say.
TAR in this case would be disastrous.
Yeah, I
I
think it,
feel that this is not the case for TAR.
yeah, okay. Dr. Hisham as well?
Yes, similarly, this ankle replacement, and for an ankle replacement, you need a foundation that is survive for long.
I think your internet connection is bad, Dr. Hisham. Yeah, okay.
Dr. Hisham? Dr.
Okay.
Hisham?
I think your internet connection is bad. Yeah. Okay, so Dr. Hisham and Dr. Rajiv say it will be disastrous to make for this patient for doing ankle replacement. So fusion or revision is much better. So I decided for the patient to make fusion. I used 2 approaches, one lateral in order to remove the plate and to prepare the lateral part of the joint, and one medial to remove the screws and osteotomize the medial malleus. And this, what I did is anterior osteotomy with translation of the articular surface, rotation of the articular surface over the talus, and putting bone graft in order to preserve the talar coverage, and then plate fixation. And when we opened, surprisingly, the joint and the talar articular surface was nice. So I said I will continue for preservation. If I found too much ulcerations in the cartilage, I would go for arthrodesis. So I decided to make for the patient this kind of osteotomy. It's anterior osteotomy this way. And here is using the Venturman distractor. And the quality of the joint was nice. Put anterolateral medial plating this way. And the talus was covered nicely. Articular surface was aligned. And then this is the follow-up of the patient. And here is the range of motion of the patient. It improved compared to preoperative. This is 1 year follow-up of the patient. The joint still working properly. The patient is in good function, good range of motion, and she is able to wear high heels. It's not the ideal, maybe better, but the patient was happy with the outcome and without arthrodesis, and she can wear high heel. So my take-home message, proper diagnosis is mandatory for a good outcome and good reduction and treatment of malleolar fractures. Proper reduction of articular surface and good alignment is keystone for successful treatment. Early revision is better than delayed surgery. Joint preservation surgery worth trial with good outcome. So thank you so much, and I'm ready for any question.
Thank you, Professor Osama. Thank you,
شكرا.
Professor Osama. Professor Osama, the current elect president of Egyptian Foot and Ankle Society. Thank you for this valuable peers in this lecture. Thank you, sir.
Thank you. Thank you, Dr. Mohammed.
Dr. Mahmoud, do we have any questions to Professor Osama?
Thank you, Professor Osama.
Thank you.
Now we can go to the second lecture with Professor Hisham Shalabi from Glasgow, UK, about the assessment and management of metatarsalgia. Dr. Hisham?
Hisham, can you share your screen, please, sir?
Your internet connection, Hisham, is
Yes.
unstable. So if
Yes.
possible, you can move to a nicer place.
Yes. The voice, Dr. Hisham, please. The voice is not obvious at all.
Is it still very difficult to hear me?
With difficulty, sir.
And
Dr. Hisham? Are you hear us?
Can you hear us, Dr. Hisham?
I can hear you very well, sir. Can you hear me?
With difficulty, sir. Your voice is interrupted, sir. If you can move to another place, sir, with a good internet connection, this will be excellent.
Now, there is any difference now?
No, still weak internet connection.
Just
Do you want me to do my talk in the meantime when Hisham's going to be in a place with internet? Can you hear me okay? Jit Mangrani
Yes,
here.
yes, we can hear you, sir. Dr.
Can you
Jitendra,
see-
how are you, sir?
Very well, thank you. Thank you for the opportunity. In fact, if Hisham's finding a place with better internet, if everybody doesn't mind, I'm actually in the middle of another meeting, so I wouldn't mind doing my talk if everybody's happy with that.
We can make an excuse from Dr. Hisham till his internet connection is being better. Dr. Hisham, can we switch to Dr. Jitendra, please?
I'll just need the screen share
Yes,
permission.
Hisham says yes, please. If you can stop sharing, Hisham.
Yeah, please stop sharing, Dr. Hisham. Thank you so much. Dr. Jitendra, please.
So thank you so much for having me online. I'm just going
Thank you,
to
sir, for participation.
and share my presentation. So just give me a second or so. And let's see if it works. The technology, hey. Right, so we've got screens and there. and share.
Yes,
That coming up.
yes, sir. Full screen, please, sir.
Amazing.
Thank you.
Hi, can you hear me okay? See me okay?
Yeah, we can hear you.
Yeah.
Well, great to be part of this, and thank you very much for the invite. I'm Jit Mangwani. I'm one of the professors in University of Leicester and work as a consultant in University Hospitals of Leicester. I have interest in rheumatoid foot and ankle, hence why this request. So thank you very much again. So I'm going to cover a few things around foot and ankle and rheumatoid. Some of the concepts mainly, some of the things that we see commonly, a little bit about pathophysiology. I think important to understand the medical management. Although we are surgeons, it is important to understand the medical management of this condition because it affects not just the bone and joints, as we know, and a little bit about soft tissues, what happens to them. So not telling you how to suck eggs here, but it's common in women, affects synovial joints, and as I said, it affects lungs, pericardium, kidney, blood vessels, everything. So important to consider the patient as a whole rather than just a particular joint. And diagnosis, although I don't know how it is in Egypt, here most of the times the diagnosis is made by either primary care physicians or rheumatologists, but at 1 in 5, we make the diagnosis because there's something that we find. For example, this is a patient who comes to our clinic for a talus bunion, but if you see radiographs carefully and magnify, there's loads of erosions going on. The findings are not typical of a talus bunion. So something going on, particularly if you see bilateral affection, enthesopathy in calcaneum for plantar fascia, or the insertion of the Achilles tendon, you must be thinking, why is this happening in this young patient, and must look into it further. And this is a typical kind of presentation of a rheumatoid patient in our clinic. As we know, it's a chronic symmetrical condition, moves progressively and destroys the joint, leading to deformity, lack of movement in patients, and disability. If we look at the pathophysiology, we know it's all related to synoviocytes, and then osteoclasts, interleukins, and TNFA. I think this is the core message here in terms of tumor necrosis factor alpha is the central, which controls recruitment, activation, degree of destruction. And particularly in the forefoot, if we look at it, there's a synovial proliferation, pannus formation, distension of the capsule, and then ligaments and plantar plate rupture. With the dorsiflexion force during gait, it leads to subluxation and ultimately dislocation of the joints. And it has another patient who's walked into the clinic, and you have to think about why they've come to the clinic at this point in time, particularly when you look at the foot and ankle, look at what their shoes, insoles, walking aids are, how they're managing at home, and manage your own expectations as a surgeon, as a hero that we think sometimes we are, and also patients' expectation. They've not come for transforming them into a normal foot and ankle. They want a functional foot and ankle. In terms of medical management, I won't bore you with those, but these are the traditional drugs. But the last point on this slide is of importance because the disease-modifying antirheumatic drugs are non-biologics, for example, methotrexate, and that can be continued throughout their journey with you in terms of operations, etc. There's good evidence around it. And also biologics, such as anti-TNFs, which may need stopping before their operation. And again, loads and loads of those are out there, and I wouldn't pretend to be a rheumatologist and know everything about them, but I think important bit to consider is follow some guidelines. I don't know whether there are local guidelines with the Egyptian Orthopedic Association, but this is what we use, the British Society of Rheumatology guidelines, and you can see one of their guidelines was in 2010, and followed by the current guideline, which says you should stop it for a 1 dosing cycle, which usually is a couple of weeks, 3 weeks before, and 2 weeks after when the wound's healed. But the important thing is in the UK, there's a trial going on currently run by my friend Hemant Pandit in Leeds, and they're looking at this very question in a randomized control trial where they're going to be looking at stopping biologics or continuing with biologics throughout the journey of patients' care and when they're having operations. So hopefully in some years' time, we will know whether we can continue to have their biologics running or not. Other medical management, or obviously shoe wear, patients are creative. As you can see in one of my patients, they make a cutout in the shoe wear to try and avoid direct pressure onto their particular area. You will hear from Venu, I think, at the end of this session, where he will talk a lot about multidisciplinary approach to diabetic foot, which is a well-established way of treating diabetic foot. But rheumatoid foot is no different. You need your rheumatologist, physio, podiatrists, orthotists, nurses, radiologists, orthopedic surgeons. So, you know, putting patient right at the center of this particular journey that they're doing with you. So consider surgery when the conservative management fails or patients not willing to accept just the custom shoes. And important to realize there are certain principles. So considerations are on the soft tissue side. You've got the consideration of immunosuppression, infection, poor skin quality, vasculopathy, rheumatoid nodules. And on the bone side, potential for higher rate of infection, osteoporosis, previous surgery, whether they've got stress fracture, and we'll see a case in a minute about that. But with many things in foot and ankle, our goal is to have a pain-free, plantigrade, functional foot that can be shod. But consider your proximal joints before foot and ankle. For example, if you've got a massive GD valgum and a planar valgus foot, it needs to be addressed higher up before you can do anything to the hind foot and have the alignment sorted out. Beware of their infected and ulcerated cases. Surgical strategy, like anywhere else, think of your sequence of operation that you're going to do. Look at the soft tissues, what drugs we've talked about. Have a friendly rheumatologist that can give you good advice. Always anticipate 2 steps ahead, because these patients have multiple joint issues. And in foot and ankle, there's that hind foot, forefoot link. Stability is important. What hardware we're going to use, because the soft tissues can be quite thin. And what mobility have they got? And also, they're going to take a period of time to recover. Are they going to cope with that? I.e., is their psychology in the adequate place? This is a case example where you've got pretty much everything affected in the hind foot and a forefoot typical sort of rheumatoid appearance. And you have to know your approaches really well. I use a lot of medial approach to the hind foot and reducing the talonavicular joint, doing the hind foot fusion through medial approach, avoid soft tissue complication. And you can see you've tackled that. Now you can tackle the soft tissue and forefoot in this patient without any major issues. So the surgical strategies, just like anywhere else in foot and ankle, are arthroplasty, arthrodesis. I was listening to some of the cases Professor Osama was talking about. You know, they're pretty much similar, whether we're doing fixation sometimes or arthrodesis. So important to consider all of these and have those in your surgical armamentarium. This was rheumatoid foot when I was training in the UK. This is one of the patients from 2005. So we've traveled quite a bit, and that's courtesy of the medical management of these patients. And if you look at 2025, we're seeing very subtle pathology now, much like any other patient that you will see will have a non-rheumatoid forefoot. But the key is you look out for particular signs, as you can see, erosion and dislocation of the third MTPJ here. So some of the operations have become historic, certainly in my hands. I wouldn't be doing any of these Fowler type operations where you take out all the lesser toe metatarsal heads and do a plantar incision. So these are almost historic operations. But the key is to have the first MTP stabilized. So first MTP arthrodesis is one of the big things to think about when you're dealing with forefoot. Metatarsal head excision is, again, not as common now as used to be previously. And no one should create a picture like this. This is a patient referred to me from a couple of 100 miles away, and they've attempted to do a forefoot reconstruction and ended up in a situation like this. So it's a very rare situation that I will actually fuse the second MTP area in addition to the big toe and salvage it that way. The emphasis now is on lesser metatarsal head preservation, and there are loads and loads of ways to do it. Stainsby being one of the common operations in the UK. You can do wile osteotomy if the joint surfaces are pretty good. or use minimally invasive distal metatarsal osteotomies. This is a typical Stainsby operation where you take out majority of the proximal phalanx and you do EDL to FDL transfer and stabilize with KYs for 5 to 6 weeks. And if you do multiple of these, yes, those get a bit shortened, but functionally patients are pretty good. And there's good literature around it, and you can see that here. Joint preserving surgery, as I said, Weil's osteotomy is one of the ones that is commonly used, but DMMOs could be done as well. And this is bringing us to the minimally invasive surgery, use of percutaneous osteotomies using high-speed water-cooled burr. So you can see that with tiny cuts, you can achieve the same amount of displacement and taking the metatarsal head off the plantar aspect as well. Again, as I said, key is metatarsophalangeal joint arthrodesis in the first joint and then doing DMMOs on the other ones. What about resection of the first metatarsophalangeal joint? The literature suggests that there is it's not a good idea. Fusion is a better idea in terms of restoring their function. So a resection shouldn't be performed. What about arthroplasty? Again, in my hands, that will be a very rare thing to do. Some colleagues do. Arthroplasty is just a silastic arthroplasty in rheumatoid, but you see a lot more of an issue with it in terms of revision surgery than fusion. So what's my approach when I see somebody with a rheumatoid forefoot? If they've got a hallux and that's got deformity in it, i.e. valgus, do I need to do arthrodesis? If the joint is arthritic, it's a simple answer. If it's very, very deformed and you want a stable first ray, then yes, do the arthrodesis. But if it's correctable deformity and the disease is well under control, then you can do scarf Aiken or you can do MIS, bunion, whatever works in your hands. Lesser toes will listen from Hisham in a minute, and he'll talk about metatarsalgia. But I think the key here is that if there is intrinsic toe deformity in the lesser toes, you need to do something about it. Weil's or DMMOs, whatever works in your hands, and multiple joints tackled in the same sitting rather than doing piecemeal operations. Midfoot, I find that you have to localize where the pain is coming from. So intra-articular injections are an important way to look at that. And hindfoot, one of the big things to take home will be stabilize the talonavicular joint. And you'll see in this particular case in a minute where the talonavicular joint is progressively dislocated almost, and you have to do a medial or a medial double or a triple arthrodesis in this situation to stabilize the talonavicular joint. If the foot goes in excessive valgus and you've got a planar valgus foot like this, it can lead to stress fractures, and they are particularly difficult to tackle. So do your medial double, get used to that approach. It's quite friendly in terms of having the access, and also once you know where the neurovascular bundle is, there is very little chance of doing any damage. This is again stress fractures. Look at the bone density, look at the metabolic bone health. Why is the fatigue and insufficiency happening? Are they on any particular steroids or anything that is contributing to it? Here's a case example with a varus ankle and stress fracture, which you can do with bone grafting and plating. One of the conditions that you have to be really particularly careful about is the rheumatoid with hyperlaxity. And these patients are particularly difficult cohort in terms of their complexity of healing. And it's very, very difficult for them to be coping afterwards because they have so many joints in different places. This is a case example of that same person. And I've done a triple fusion there with doing their gastroc recession. And I've now gone on to actually go and do their ankle fusion over the years because they've now progressively gone into valgus through the ankle joint. Use 3D printed models. I do quite a few of them. We have 3D printed models in our hospital. And when you're doing revision surgery in this cohort of patients, definitely think of having a model beforehand. Do your osteotomies on that and see what correction you can achieve. You can also do PSI, patient-specific instrumentation, for certain osteotomies in this age group. think important to think about fusion of the ankle joint. Traditionally, if you look at it, the literature in 90s, it was small numbers and wound infection complication was a particular issue. But over the course of many years now, we've traveled in this space and done loads of arthroscopic ankle fusions. Is a case example, and we published on this not so long ago. And you can correct large deformities of almost 25 degrees of varus valgus with differential shaving and doing arthroscopic ankle fusion, which is great for their soft tissues, and wound complication is next to nothing. What really matters to the patient is not clear. So we have a variety of patient-reported outcomes, but they're not specific for rheumatoid. And this is the only paper in a systematic literature review which outlines that we need a separate set of core outcomes for rheumatoid patients. What about ankle replacement? I think one of the cases for Pilon that we talked about was there's a good indication. I think in rheumatoid, certainly a good indication, as long as the bone quality is not absolutely terrible and the soft tissue is good. And these patients do well because adjacent joint disease is always there. And one of the things about ankle replacement is if you preserve some movement in the ankle, they're going to do pretty okay. If there is a combined involvement of tibial-talar and subtalar joint, then obviously a TTC fusion is a pretty good way of tackling that. What about pantalar fusion or double, triple with a TAR? I think pantalar fusion, yes, sometimes there's no choice, but my preference is to do a triple, and if you can have an ankle replacement on top, certainly go down that route and maintain a motion segment in the ankle. Rheumatoid nodules can be common, so sometimes those are the only things that are giving them grief with their shoe wear. So it's important to take care of those and look out for tendinopathies, particularly tib and tib post, tendon Achilles and Peroneal, and here are the pictures of all of them in one. So any of them can be affected, or multiple tendons can be affected. So whilst you're assessing them, it's important to pay attention to that. So in summary, we know rheumatoid is a systemic disease, high index of suspicion when you have somebody coming with bilateral symmetric involvement. Manage non-operatively where you can, but operations may become necessary. Biologics, think about them, how are you going to manage before and after. First ray fusion rather than joint preservation, lesser toes joint preservation rather than doing anything different. And beware of the rheumatoid patient with a hyperlaxity, because that can catch you out. But one of the things I must say in my practice, if you think of the whole patient, yes, they can be very challenging problems to solve, but they are one of the nicest bunch of people you look after. The job you do is rewarding, and it makes a massive difference to their quality of life. So it's worth spending time and effort into it. Thank you very much for your patient listening. I'm just doing a couple of quick plugs here. One is I'm the editor for Footprint, which is the official bulletin of British Orthopedic Foot and Ankle Society. And we are now creating a global platform. So Indian Foot and Ankle Society and AFAS and EFAS and loads of other foot and ankle societies have joined us as our partner organizations. So Egyptian Foot and Ankle Society, please do come and join us. And the other thing is about leading a national think tank on bunions in the UK. Some of you may or may not know that there are 12 million people in the UK plus that have bunion. So we're creating streamlined pathways for their care, and there's a fair amount of work going on in the background with that. So if you get any ideas, have any interest in research, etc., in this field, please do reach out to me. My details are on there. Thank you.
Thank you so much, Mr. Mangwani, for your presentation and for your participation. We come again to Dr. Hisham. You are with us, Dr. Hisham? Dr. Hisham?
Are there any questions I can answer?
I think.
Any questions?
Stunned silence.
I think we can answer the question, Dr. Mangwani, by writing in the chat box if possible, sir.
Yeah, sure.
Thank you so much, sir.
Thank you. I'll be peeling off in a few minutes if that's okay. Great to see you all, and thank you for involving me.
Thank you so much, sir, for your participation. It's an honor. Thank you so much. Thank you,
Thank
sir.
you. Bye-bye. Bye.
Thank you, sir.
Can you hear me now?
Dr. Hisham, the voice is not obvious at all. Dr. Hisham, we cannot hear your voice, sir. Okay, can we go to the next speaker, Dr. Hisham, till we solve the problem? Okay.
I'm all set to take up my talk.
Yes, please. Our next speaker
Provided.
will be Mr. Rajiv. Mr. Rajiv Shah.
Yeah.
Thank you so much for joining us, sir.
Thank you.
Mr.
Can
Rajiv will
I-
speak about a
let me-
very important topic, which is the calcaneal malunion. I'm right, sir?
Yes.
Thank you so much.
I hope
Full screen, sir, please.
my screen is seen.
Yes, sir.
Yes.
But full screen, please, sir. Slideshow.
Yeah, just a minute.
Okay. No, you have stopped sharing, sir.
I'm just trying to share it again.
Yes. Yes, it's shared.
Yeah, I'm just taking it to the slideshow mode. Yeah. Am I audible? And I
Yes.
hope my
Yes.
screen is seen. Okay. Thank you. So developing countries have epidemic of calcaneous malunion. And these are the calcaneous malunion cases. The reasons are most calcaneous fractures are either not operated or just neglected. And the second reason being many of the operated cases are with poor surgical execution. And look at this, all operated cases of calcaneus malunion, poorly executed. So here I'm going to talk about calcaneus malunion, my approach and the way I manage this. I represent India. I was a past president of Indian Foot and Ankle Society and the first foot and ankle surgeon of India. When pain being the feature, I approach case of calcaneus malunion like a case of back pain to find out every possible pain generator for a given case. And in history and in clinical examination, you look for the type of the pain, location, radiation, aggravating, elevating factors. Look at the swelling, disability. Look at tendon, nerves, muscles, fascia, joints, deformity, arches, and movements. And obviously, don't forget to look at the gait, footwear, and orthotics. When it comes to diagnosis, you could see this picture taken from my book chapter that this could be the various pain generator. If you see the lateral image of calcaneus, and this could be various pain generator if you see the axial image of a calcaneus fracture, malunion. Diagnostic injections in and around joints, tendons, and nerves, they help to identify pain generators. And I use them a lot in my practice. So far as radiology is concerned, you have set of your plain X-rays, weight-bearing X-rays, Excel images, broadened views, and obviously opposite side X-rays. And you can measure various angles, Bowler's and Jason's angle. They are distorted. And if you talk about talocalcaneal height, talar declination angle, or a calcaneal pitch angle, all these parameters are distorted. And in an axial view, you look at the lateral wall exostosis, hindfoot malalignment, and calcaneus shortening. CT scans are very vital to look at the degree of the joint arthrosis, presence of non-linear or subcystic lesions, loss of calcaneus height, widening of the heel, and subfibular impingement. Obviously, hindfoot malalignment is also nicely seen in the CT scan. And CT scan is mandatory for preoperative planning for this complex deformity. Talking about classifications, we had Stephen and Sanders classification, which classified calcaneus mal into type 1, 2, and 3, where 2 being a generalized malunion, complete subtalar arthritis, and 3 being arthritis with deformity, either varus or valgus. The second classification was given, which was a deformity by classification, base classification by Zwip and Rambilch, where they divided these cases into type 1, 2, and 3, wherein they added addition of heel height into type 3. Type 4 was lateral translation. Type 5 was with the inclusion of the ankle. And type 0 was any malunion without subtalar arthritis. When we tried to classify our 98 calcaneus malunion cases with both this classification, we failed miserably. At least 40% of our cases were not covered under Zwip and Ramel's classification, and more than 60% of our cases were not covered under Stephen and Sanders classification. So we came up with our own classification of calcaneus malunion, the Adain's classification. It is a pain-generated based calcaneus malunion classification where there are 6 major groups, where group A is arthritis, D is for deformity, E is for exostosis, I is for implant, N is for the nerve issues, and S is for the soft tissue problems. So if you see, arthritis could be arthritis of subtalar joint. It could also be arthritis of calcaneocuboid joint, and you could also have in a very, very late presenting cases, arthritis of the ankle, transverse tarsal, or a midfoot joint. The deformity mainly is in the form of heel varus. There could also be cases where you have heel valgus, like I have shown in this case. The heel shortening is one another deformity you see, and the dorsiflexion of the talus into the ankle mortise is one more very common deformity. E for exostosis, where you have very commonly lateral wall exostosis. You could also have a posterior exostosis. In a malunited case, you might have a medial exostosis and a plantar exostosis, or you could have combination of all. I is for implant, and these are all implant-related complications giving rise to calcaneus malunion issues. N stands for nerve problems. It could be sural nerve issues, it could be posteriotibial nerve issues, and S for soft tissue problems like tendoachilles contracture, toe deformities, claw and hammer, or mallet toes, and sometimes fat pad atrophy in a very, very severe case. So this is how this Adain's classification comes, where even reflex sympathetic dystrophy could also be classified under soft tissue problems. Now, how do I manage calcaneus malunion? The conservative management is always tried for at least 4 to 6 months, but by and large, it usually fails. The conservative management includes activity modification, topical analgesics, NSAIDs, insoles and AFO, physical therapy, and sometimes intra-articular corticosteroid injections. At surgical management, every pain generator is addressed on its merit. So if there is an arthritis, you could think of doing joint salvage procedures in form of realignment with osteotomy and fixation. But most often than not, for arthritis, you end up doing joint sacrificing procedures in form of either arthrodesis plus or minus arthrodesis and osteotomy. What does literature say about joint salvage versus joint fusion, subtalar fusion for a malunited calcaneus? Till date, literature has shown 3 papers onto joint preserving osteotomies for malunited intra-articular calcaneus fracture. So typically, reconstruction is reserved for young patient who is active, and the malunion is less than 6 months duration with a good cartilage and good bone quality, and patients are informed that intraoperatively, if we find that the cartilage is not good, we may change our procedure to fusion. And fusion could be done at any age, where the patient has long duration malunion, cartilage damage, poor bone quality, severe malunions all fall into fusion. Infections and poor soft tissue also go for fusion of subtalar joint. Deformity is treated with corrective osteotomy. Exostosis is treated with exosectomy. Nerve issues could be treated with release, neurolysis, neurectomy, and burial procedure. And implants requires implant extraction, revision, debridement, sometimes antibiotic if there is infection. And soft tissue issues have issue-specific management. This ST fusion in calcaneus malunion, one has to follow 7 big principles for the same. Number 1 is meticulous joint preparation, scraping of the cartilage, drilling of the subtalar bone, fish scaling of the articular surfaces is very, very important. The another important thing is to correct the deformity and not to fix subtalar fusion into in situ kind of a position. The third important thing is for a post-traumatic subtalar arthritis, try to fuse all 3 subtalar joints and make a construct which is robust, and it fixes not only 2 screws in posterior subtalar joint, but one has to add an anterior screw which keeps talus into plantar flexion. The another important landmark work you need to do for ST fusion is to add bone grafts because there are defects which requires to be filled up. A dissection subtalar fusion when you have a subtalar osteoarthritis with a dorsiflexion of the talus and the height of calcaneus and talus is lost, you have to go in for a surgery where you need to do dissection calcaneus subtalar fusion where a tendoachilles open lengthening followed by a vertical approach of the lateral extensile approach. You take the iliac crest bone graft, pack the iliac crest bone graft, lift up the height, and make sure that the talar declination angle is corrected like this done in case. You do have one more bone graft site when you can take the bone graft from the posterior part of the calcaneus, little anterior to the tendoachilles, and this good bone graft you can harvest, and you can get out with this bone graft doing a dissection subtalar fusion without going to the iliac crest. And this is how things look diagrammatically. Now, let me go and show you some few cases of calcaneus malunion where this was a type ADE case where arthrodesis, deformity, and exostosis. There was subtalar arthritis, there was heel valgus, there was lateral and posterior exostosis, and heel was in valgus. And this case was treated with lateral exosectomy, posterior exosectomy with a extensile lateral approach, and dissection subtalar fusion together with correction of the heel valgus and heel height restoration, followed by lateral plus posterior exosectomy, went on to heel. And so heel valgus can also be associated with calcaneus malunion, the message I want to give through this case. And heel valgus might as well need correction at the joint by gross dissection or below the joint by medial displacement calcaneal osteotomy. Another case was the case ADES where you have an arthritis, deformity, exostosis, and soft tissue problem. If you see the problems in this case, there was subtalar arthritis, there was calcaneocuboid arthritis. None of the classification is mentioned about the calcaneocuboid arthritis except Adain's classification. Heel was in varus, there was shortening of the heel, there was lateral wall exostosis, and there was clotto. An extensile lateral approach was taken for this case, and the approach was taken dorsally to expose the calcaneocuboid joint, and the double type of bone grafting technique was used for calcaneocuboid joint here. The grafts were packed, cancellous grafts were packed, and subtalar plus calcaneocuboid fusion was done. It was a dissection subtalar fusion, in situ calcaneocuboid joint fusion, lateral plus posterior wall exostectomy, correction of the heel varus, and correction of hammer and malletto was also done. And that's how it was treated. And this is how the final result looked like. So calcaneocuboid joint involvement is quite common into calcaneus malunion, and toe deformities also needs to be addressed while you are addressing the calcaneus malunion case. The case 3, where you had subtalar arthritis plus heel was in varus. Here the varus was so much that we had to do Dwyer's osteotomy plus subtalar fusion, and this is how it was fixed. So varus would need Dwyer's osteotomy, valgus would need medial displacement calcaneal osteotomy. Another case where we had to undertake many procedures, this was like presented to us 10 years post calcaneus malunion. And if you look carefully in this case, the elements of malunion, this was ADENS, adens type of variety, where there was arthritis of subtalar joint, there was shortening of the heel as a deformity, there was talus dorsiflexion as a deformity, we had a plantar exostosis. This patient had tendoachilles shortening. This patient had a heel into valgus. Patient had a claw and hammer deformities. And patient also had a medial exostosis, which gave rise to secondary tarsal tunnel syndrome. And this patient required destruction, subtalar fusion. Patient had to undergo talar dorsiflexion correction through this. Plantar exosectomy was done. Heel valgus was corrected. Medial exosectomy and tarsal tunnel release were done. And then all the clotto were corrected. So long-standing cases would have multiple procedures to correct this kind of malunion. Another case, a female of 52 were non-diabetic and somebody attempted post-calcaneal fracture malunion subtalar fusion. And look at the kind of fusion which was done. The issues were that this was a clinical look of this patient. Broaden's view showed non-union of the calcaneus malunion treated with subtalar fusion. It was ununited. The screw had broken. This were Broaden's view. What to do? Where fully threaded screws were used, there was no compressionate fusion and implant did fail. Both the screws were in center. They were not catching hold of the multiple quadrants. There was no compressionate fusion and ultimately implant has to fail. So it was addressed with an extensile lateral approach. The screws were removed and a use of larger and longer screws with a different track and fusion of all facets anterior and middle was done with the screws and a plate was also added. And this is how, and screws were spent and bone grafting was as well done. And this is how it went on to heal without any issues. And this is what we were done. So ST fusion is not a forgiving procedure. The last but important case, an obese female of 31 had a fixation of this kind at United States of America and injury axes were missing. She underwent this kind of fixation and then she had terrible pain. She called me in India saying that, doctor, I have a terrible pain. She had an access to this kind of access. I said, go to your doctor, get your implants removed ASAP. So implants were removed. She still had lot of pain, lot of burning, lot of tingling numbness, and she had inability to walk. I said, doctor has not removed the medial implant. This implant might have caused some kind of problem into a posterior tibial nerve and flexorosis longus tendon and secondary tarsal tunnel syndrome. Please get this screws removed. So she had this kind of problem. She got this screws removed, but still the pain was persistent. And she then calls me and says, doctor, I have a pain. I said, nothing doing. Whenever feasible, you need to come down to India. It was after about 1.5 years that she came to us with this kind of X-ray pictures. Malunited calcaneus, patient was unable to walk, lot of diuretic pain, tingling numbness. And look at this picture where she had a clawing of the toe and she had a smashed heel fat pad. These problems, if you list out, she had a ST arthritis, she had a talar dorsiflexion, she had contracture of tendoachilles, heel was in gross varus, heel was short, there was sural nerve injury because of the plate, there was posterior tibial nerve injury because of the screws placed medially, there were clawing of the toes, and she also had a fat pad atrophy. All these problems, we thought now we'll need to take through the surgery. This was classified as arthritis, deformity, implant, nerve, and soft tissue problems, EDINs. On exploration, there was non-union between body and anterior fragment, and there was subtalar arthritis between body and the posterior facet of talus. So we had to take 2 bone grafts from iliac crest, and then we fixed up body with an antiofragment with the bone graft, and we did a subtalar fusion destruction with mid-body and talus. Together with that, she also required neurolysis and tarsal tunnel release, plus correction of all clawing of the toes as well as claw helix. So non-union really requires high index of suspicion. Friends, to conclude, one of the most common but challenging problem is calcaneus malunion. If we go pain generator based evaluation, then it would guide in managing this cases very swiftly and you can get reasonably good results. Again, thank you very much for giving me this opportunity to represent my country in your esteemed meeting. Thank you very much. Any
Thank you,
questions?
Dr.
I'm
Rajiv.
happy to answer.
Thank you, Dr. Rajiv. Firstly, I would like to thank you about your term about the correction of malunited calcaneus. We should deal with this case as a low back pain case. We should try to find the proper cause for pain and deformity, because we can deal with subtalar fusion, but the problem is exostosis, and so the pain will be presenting after the correction. So I would like to thank you very much about your term that we should deal with it as a low back pain. Any questions for Dr. Rajiv? Any questions? Thank you, sir, for your valuable presentations. Now we,
Thank you very much.
Dr. Hisham, can you join us? Dr. Hisham Shalabi?
Now, it is still difficult.
The sound is interrupted. So thank you, Dr. Hisham, for your valuable trials. We are very sorry. Now we can shift for the next speaker, Professor Mohammed Laklouk. Dr. Mohammed.
ايوه يا باشا انا مع حضرتك.
Okay, sir. Dr. Mohammed will talk to us about the how can approach found congenital vertical talus in adolescent age.
بسم الله الرحمن الرحيم. في البداية بنشكر أستاذنا سيادة العميد الأستاذ الدكتور محمد الأشهب على المجهود الخرافي والرائع اللي بيعمله ده، واللي استمر فيه سنين وسنين، ما كانتش ظاهرة واكتفى بيها، لا ومستمر فيها، وكل عام بيبقى أكبر وأحسن من اللي قبله. فربنا يجازيك خير جزاء على اللي بتعمله معانا ده يا فندم. We talk about today about the management of congenital vertical talus in adolescent age, a case-based discussions. بسم الله الرحمن الرحيم. ويسألونك عن الروح قل الروح من أمر ربي وما أوتيتم من العلم إلا قليلا. صدق الله العظيم. It's the site of my YouTube channel if you want to see any of our lectures. Our agenda today, we shall talk about introduction of congenital vertical talus, etiology, pathoanatomy, clinical picture, management at adolescent age, and case presentation. Congenital vertical talus is a type of congenital foot anomaly with unknown etiology and low incidence. Usually occur or detected at birth, characterized by a presence of rounded prominence on the medial aspect of the foot and plantar surface of the foot. This is due to abnormal location of the head of the talus and dislocation of talonavicular joint. It is first used this term by Henkin in 1914. There is other synonyms for congenital vertical talus like congenital convex base valgus, reverse glove foot, congenital valgus flat foot, rocker bottom foot, talus convex base valgus, or talus verticalis. Incidence about 1 every 10,000 pairs, male and female are equal, bilateral case in about 50 cases. Etiology, idiopathic in 50% of case. Neurological abnormalities like arthrogryposis, myelomeningocele, spinal muscular atrophy, neurofibromatosis, and CP. And genetic syndrome in the abnormality in trisomy 13 and 15 and 18. We shall talk about the pathoanatomy. First, talk about bone change in the calcaneum. At first, there is hypoplastic testicular talus. Normally, this is the shape of the normal testicular talus and the position of the talus above the calcaneus. But if the testicular talus is hypoplastic, there is medial deviation of talus and head of the talus, like this picture. In this picture in the right above, there is the blue area is unsupported area of the talar head in the case of the normal testicular talus. But in the diagram below, there is a big area of unsupported area of the talar head with hypoplastic testicular talus. The calcaneus also is plantar flexed, hypoplastic anterior and middle facet, and misshaped posterior facet. The talus also abnormal. There is talus is pointing straight down, and only posterior third of articular surface of the talus articulate with the tibial plafond, flattening dorsolaterally, and the articular surface expand to accommodate articular surface of displaced navicular, and also it is plantar flexed. The navicular also is in abnormal position. There is dorsolateral displacement of the talus. It is also hypoplastic and wedge shaped. In navicular also, there is dorsolateral displacement and displaced over the talus. According to the Navi-Pontic classification, these three types, either grade 0 or grade 1 or grade 2. Also, cuboid bone is hypoplastic, especially in the plantar half in severe cases, and it is slightly displaced. The abnormal pathoanatomy in the ligaments, there is stretching of spring ligament, anterior fiber of the deltoid ligament, and the medial fiber of bifurcate ligament. There is contracture of the calcaneofibular ligament, interosseous talocalcaneal ligament, sensor retinaculum, dorsal navicular ligament, and posterior ankle and subtalar joint. Also, abnormality in the muscles, there is contracture of the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and extensor hallucis brevis. Also, there is contracture of peroneus tertius, peroneus longus, peroneus brevis, and Achilles tendon. Joint exchange, there is contracture of the talonavicular joint, calcaneocuboid joint, and ankle and subtalar joint. Radiological assessment of congenital vertical talus, since most children with vertical talus are seen in the newborn period, there is most of the tarsal bone are radiolucent in this age. The radiographic evaluation is focused on the relationship of the ossified talus and calcaneus and tibia. Also, as well as relationship of the metatarsal to the hind foot. Time of appearance of ossification center in the foot, the cuboid appear at the age of 1 month, cuneiform in 2 years, and navicular bone in 3 years. Radiological assessment by doing standard classically AP and lateral view. Also, lateral X-ray enforced dorsal and plantar flexion of the foot, like this X-ray. In older children, we can do a standing AP and lateral view. Radiological measurements, we can measure talocalcaneus angle. It reflects the alignment of the hind part of the foot at normally about 15 to 55 degrees. It is measured also in lateral view and AP view. Talo first metatarsal angle, it reflects the relation between the forefoot and hind foot. Also, it's measured in both AP and lateral view. Tibiotalar angle is measure of position of the talus. Tibiocalcaneal angle is measure angle of the quinus. Talar axis first metatarsal base angle, it measures the dislocation of the talonavicular joint. and it also classified to 3 degree. If it is less than 30 degree, it is good. 30 to 60 degree subluxated. More than 60 degree, it is dislocated of the navicular bone. Prenatal ultrasound diagnosis of the congenital vertical talus is easy by a sonar. Calcaneal picture, congenital vertical talus is characterized by abnormality in the forefoot in the form of abduction and dorsiflexion. Also abnormality in the hind foot, either valgus or equinus position. This abnormal creates in the anterolateral aspect of the foot. Foot is everted into valgus and externally rotated. Head of the talus and plantar medial aspect of the foot can be palpated due to abnormal position of the head of the talus, and the calcaneus also is in equinus position. If this case of the congenital vertical talus is left untreated, more rigid deformity will occur, and adaptive change in the tarsal bone, callosities around the head of the talus, and heel doesn't touch the ground, and shoe wear become so difficult, and pain is inevitable. Treatment of congenital vertical talus, the goal of treatment to restore and maintain normal anatomical relationship, either by conservative treatment or operative treatment. Most authors agree with the congenital vertical talus should be recognized in birth and treated before 2 years, but if it is delayed more than 2 years, we need more aggressive procedure to correct this abnormality. Conservative treatment consists of reversible Ponseti technique, and it is not beyond the scope of our talk. So we shall not talk about reversible Ponseti technique. And after serial manipulation, we can do minimal invasive approach according to the TOPS technique by doing percutaneous fixation of the tenonavicular joint using K-wire and the percutaneous tendo-Achilles lengthening. If the tenonavicular joint is not reduced, we can do a small incision medially. We do dorsal capsulotomy of the tenonavicular joint, and we can do fractional lengthening of the tibialis anterior or peroneal brevis tendon. Once tenonavicular joint is reduced and fixed by K-wire, we do percutaneostomy of the tendo-Achilles. Operative treatment of the congenital vertical talus, it was the mainstay of the treatment. The type of procedure is based on the age and severity of the deformity and the surgeon preference. Children up to 3 years, we can do open reduction of the tenonavicular joint either in 1 or 2 stages. More than 3 years require excision of the navicular bone. From 4 to 8 years require open reduction, and we can do extra-articular arthrodesis of the subtalar joint. More than 12 years require triple arthrodesis. In literature, different types of reconstruction have been described, either single stage or 2 stage. Single stage is the first stage, 2 stage operation. And the first stage, we do lengthening of extensor digitorum longus, extensor hallucis longus, and tibialis anterior, and capsulotomy of tenonavicular, calcaneocuboid, and talocalcaneal joint. Second stage, we do tendo-Achilles lengthening and the posterior capsulotomy of the ankle and subtalar joint. Single stage release consists of 4 basic components. First step, lengthening of the tendo-Achilles and release of the posterior ankle capsule and subtalar joint. Second stage, release of the tenonavicular joint and the reduction of the head of the talus in the tenonavicular joint and fixation by K-wire. Third step, lengthening of the 2 extensor and peroneal length, and the calcaneocuboid joint is also reduced if necessary. Fourth step, tibialis anterior tendon transfer to the head of the talus or neck of the talus, either by doing perforation through the head of neck or by using anchor. Another way of treatment is there is a resection for arthroplasty. Naviculectomy. Resection, arthroplasty, or naviculectomy may provide an alternative to the above procedure. Advantage of the naviculectomy is the less traumatic nature and relatively simple. It is a viable and less traumatic surgical option. It can restore foot posture and function in children without increasing any intermediate or short-term complication. The philosophy behind the naviculectomy, it will relax the pre-tension ligaments. especially around the talonavicular joint. It creates a more room for repositioning of the fore and midfoot in the hind foot. Reformation of the concave medial arch. Although additional limited soft tissue release may be needed in naviculectomy procedure, it remains less traumatic than classic peritalar soft tissue release. The relative flexibility of the medial arch and the foot is related to the minimal dose of soft tissue dissection. Telectomy, it is another way for treatment for resection foot arthroplasty. It has been used to address similar complex subsets of clubfoot and congenital vertical talus. This advantage of the telectomy, it affects ankle and foot biomechanics, clinically complaining, affect ankle stability, produce abnormal and weak joint movement due to create lever arm deformity, disturb blood distribution around ankle and foot. It done also especially in ambulatory children. We shall now talk about our cases of naviculectomy for treatment of congenital vertical talus in adolescents. The first case, male patient, 13 years, with bilateral fixed planovalgus foot, the right rigid hind foot, equinovarus convex sole, and forefoot abduction. This patient also complaining from skin problem called lamellar ichthyosis. This is a photo of X-ray, standing X-ray in the right and MRI in the left. At first, we do direct medial incision over the talar head. We do right side with planning for naviculectomy with limited soft tissue release according to the procedure, a la carte procedure, according to Ilsoki et al. 2020. Then, if we found a difficult reduction of talonavicular joint, so we do detachment of tibialis anterior, tibialis posterior tendon in preparation for later rerouting. Then do subbrostal naviculectomy and elevation of the talar head. Then lengthening of the tendon Achilles and release posterior ankle capsule. Elevation of the talar head and retrograde K-wire passed through the first ray with the talus. Normal range of movement post-operatively. At the end of the surgery, formation of the medial longitudinal arch. This is a photo of the leg before surgery and after the surgery. We can compare photograph of the patient preoperatively and post-operatively. We can show the deformity in the right foot. It is corrected completely after surgery. Post-operative photos of both feet. Preoperative in the right foot photo and post-operative. Also in the left, preoperative and post-operative in the right. Also, we can compare the X-ray before the surgery and after the surgery and restoration of the curvature and medial longitudinal arch of the foot. Standing X-ray for preoperative and post-operative. We can see the talar axis first metatarsal base angle, which is completely corrected. It's now nearly good result because it is about less than 30 degrees. Also, if we compare before surgery and after surgery by using talocalcaneal angle, we can see there is a marvelous correction of this angle. And this comparison of the patient preoperative and post-operative. The second case is a male patient, 11 years old, with right fixed planovalgus foot. This is a photo preoperatively for the patient. And this is X-ray for lateral X-ray in dorsiflexion and plantar flexion. MRI, we can see the wedge shape of the navicular bone. Also, we do naviculectomy and limited soft tissue release. The same procedure as the first case, and the correction is maintained by K-wire passing from first ray to the cuboid. And we compare preoperative and post-operative photography for the patient. At the end of the surgery, we can see the reformation of the medial longitudinal arch. We can see the patient, the walking gait of the patient preoperatively and post-operatively nearly normal. and X-ray, EP and lateral X-ray after 8 months follow-up for this patient. Third case, male patient, 9 years old with bilateral fixed planovalgus foot, briefly operated at age of 1 year. He has a rigid hind foot equinovalgus and convex stool and forefoot abduction. Also, we do naviculectomy and limited soft tissue release. This is a preoperative X-ray. The medial incision, detachment of tibialis anterior and the tibialis posterior tendon, and do oblique incision in the lateral aspect for release of calcaneal joint. Anteriorly, we can do lengthening or fractional lengthening of extensors of the toe. Posteriorly, we do lengthening of tendon Achilles and release posterior ankle capsule. And then we do naviculectomy. This is a photo during operation after restoration of the talonavicular joint. In the first month follow-up X-ray, we can see normal alignment of the foot after naviculectomy. And it's 8 months follow-up, and the photograph of the patient after 8 months follow-up. Thank you.
Thank you so much.
Thank you, Dr. Muhammad.
تفضل يا دكتور محمود، تفضل يا فندم.
Thank you, Dr. Muhammad, for your valuable talk.
Thank you.
The message is very important as firstly, not for our junior colleagues, not all planovalgus deformities is a flat foot deformity. We have a congenital vertical talus, we have a fibular shortening, we have molar Weiss syndrome. So you should exhaust yourself for the correct diagnosis in order to prepare your patient for your surgery. Thank you, Dr. Muhammad. Any questions?
Thank you, Doctor.
Any questions?
I think no question.
The next lecture is Pilon fracture with Professor Amr Farouk, Ain Shams University. Dr. Amr?
Yes, Dr. Mahmoud. Can you hear me?
Yes.
First of all, I would like to thank Professor Muhammad Al-Ashhab and Dr. Mahmoud Abu Zaid for their very nice invitation and for their great effort. It's my pleasure طبعا to talk about after Professor Muhammad Lakluk. He is giving us a very complicated subject, and now we are back to trauma that is common.
A very complicated subject.
Trauma cases that are very common and we see it every day. I will give a short lecture in the form of a case presentation about Pilon fracture, and let me start.
Full screen, please, Dr. Amr.
Yes. Let me start by this case. This is a male patient, 37 years old, that fell from height, and he is presenting to the ER just after the trauma. I will give some questions, and you can freely write in the chat box your answers. Do you think these X-rays are enough for making a full diagnosis of the patient? Sorry. Yes, CT is mandatory. Of course, CT is mandatory, but is CT indicated in all cases of ankle fractures, or why do you think CT is highly indicated in such a fracture? Is it a normal ankle fracture or a POTS fracture? No, of course not. CT is indicated here because we think that there is a violation or damage for the tibial plafond. And this is where CT is indicated in ankle fractures, not in simple bimalleolar fractures, but when we suspect that there is a posterior fragment or posterior malleolar fractures, we have to do CT. When we see that the tibial plafond is damaged like this, we have to do CT. So CT is mandatory in such cases in order to plan our treatment. Pre-operative planning, like Dr. Abdullah is saying. Yes. So this is the CT. Does it add any information for us? Of course, a very highly comminuted distal tibial fracture, and the fibula is also fractured, a high lateral malleolar fracture. So what is next? The 3D reconstruction is very useful for me in these cases because you can see the fragments, each fragment separately. So here we can see that there is a large posterolateral fragment in the distal tibia and a medial fragment, and also a large anterior fragment and anterolateral fragment. So what is the name of this anterolateral fragment of the distal tibia? Yes, chapeau fragment, Dr. Abdullah, Dr. Ayman Mustafa. It's a chapeau fragment, yes, and it's very important in the stability because it is an avulsion of the anterior tibiofibular ligament. So what's next? We have to differentiate between ankle fractures, which are POTS fractures, and between Pilon fractures. Usually the ankle fractures result from a low energy trauma, like twisting trauma of the ankle, as we see every day in the emergency room. So this twisting low energy trauma causes malleolar fractures, usually with minor articular damage. Also, the skin condition in the POTS ankle is rarely as bad as what happens in the Pilon fracture. Pilon fracture is usually resulting from a high energy trauma, like a motor car accident or falling from height, in which the talus moves directly into the tibial plafond, causing major articular damage in the distal tibial plafond. And this also affects the soft tissue. We are always in the Pilon fractures very aware about the soft tissue condition. So what to do next? As you have written here, Dr. Ibrahim is saying examination of soft tissue. Yes, completely correct. So Pilon fracture is not as simple fracture as POTS fracture. So this is the soft tissue of the patient. What do you think? Yes, I think it's very difficult in this case to do a primary definitive fixation. So as you all have written, we go to external fixation. So this is a question for you. You have already answered the question. We go for conservative management or for slab and anti-edema measures, followed by open reduction internal fixation, immediate internal fixation, or spanning fixator, followed by another stage of open reduction internal fixation. I think all of you already answered the question by the need of spanning fixator at the start. So this is what we call staged protocol. Staged protocol. we go to spanning external fixator at the start. And what is the value of this spanning external fixator? It allows soft tissue relief and blister healing. As we see in the picture, there is bully. And as you all know, we have two types of bully: serous bully or hemorrhagic bully. Putting an external fixator gives time for these blisters to heal. Second stage is removing the external fixator and going to the definitive fixation. So, what can I do during the stage of external fixator? After doing the external fixator, I have to scan the patient again. What's the meaning of scanning the patient again? I have to do new imaging for the patient after putting the external fixator. So that's what we did. This is the X-ray after putting the external fixator. And the type of fixator that we use usually in these ankle fractures is what we call a delta frame. A delta frame, like what you are seeing in the picture, is the most commonly used fixator for dealing with ankle fractures. So, do you think X-ray is enough after doing the fixator for doing the preoperative planning of the definitive fixation? Yes, we need another time to repeat the CT. So that's what was done for the patient, repeating the CT once more after doing the external fixator. The axial cuts here are very clear, and the axial cuts here is talking about a very recent concept in dealing with Pilon fractures, which is the column theory. I see the fracture fragments and I put them in columns. This is a posterolateral column and a medial column and an anterolateral column, and the fibula is the last one. So it's clear here that we have about 3 large fragments: posterolateral, medial, and anterolateral fragment in the tibia. So what is the sequence of fixation? If I am putting now my preoperative plan, what is the sequence of fixation of these 3 columns? Let us see. Let us see. Fibula first, yes. Dr. Ayman. Fibula, Dr. Abdullah is saying fibula, posterolateral, and then medial. Reduction from posterior to anterior, Dr. Ibrahim. Okay, now we are coming to this in a while. Now let us see what is the best time to remove the external fixator and shift to the internal fixation. Do you think there is a certain time for this? Wrinkle sign, yes, correct. Within 3 weeks, 3 weeks, maximum 2 weeks, Dr. Ayman. Wrinkle sign, soft tissue improves. Yes. Best time to do this is to wait until soft tissue resolves, blisters heal, and we can shift in one session from external fixator to internal fixation. But maximum allowed time is not more than 2 weeks. Why not more than 2 weeks? Because if I wait more than this, it's very likely that there is contamination or there is pin tract infection that hinders me from doing the whole steps in one session. So if I have pin tract infection, I have to remove the fixator in one session and wait for a while until the pin tract infection resolves, and then move again to the second step, which is internal fixation. So the best thing is to do this before than 2 weeks. But of course, I have to be sure that the soft tissue is already resolved. So not more than 14 days, please. So again, I have to plan my surgery now. And this is the sequence of fixation. I start from posterior to anterior, as most of you have said. Sorry. Someone is asking. We have low incidence of infection. Yes. We have very low incidence of infection if we have done this during the first 7 to 14 days. So if this is our sequence of fixation, as you have said, the fibula first, and then the posterolateral fragment of the tibia, and then moving from posterior to anterior in this sequence. What will be the position and the approach I am going to use in order to fix? Nowadays, we are using the posterolateral approach very commonly in these types of fractures. This is an easy approach and a direct approach we can use to attack both the fibula and the posterolateral fragment or the posterior malleus. So this is where we are going to start. But of course, after this, I have to do another approach in order to reach the anterior and the medial part of the fractured tibia. So I am going to use dual approach, as Dr. Abdullah said, starting by the posterolateral approach and then an anteromedial approach. So what will be the position of the patient? I can put the patient first in the prone position to do the posterolateral approach. And after I finish fixing the fibula and the posterolateral fragment, I have to change the position of the patient to supine position in order to do the anteromedial approach. But this is taking too much time in order to start my operation from the start after changing the position of the patient. So is there any other technique? Yes, we can put the patient in like lazy lateral position and start by the posterolateral approach while my assistant is helping me to do internal rotation of the leg in order to be able to do that posterolateral approach. And then I change the position. My assistant helps me to do a lot of external rotation to reach the anteromedial approach. Of course, this is not easy, but it has a learning curve, of course. So start with the posterolateral approach, which is an easy and direct approach just between the Achilles tendon and the lateral malleus. And I can use this approach to attack both the posteromedial, the posterolateral fragment. And of course, I put on it a plate like this, the lower right photo, which shows the plate, anti-glide plate lying on the posterior surface of the distal tibia. It can be either a 1/3 plate or a T plate, which is used for the distal radius. Again, I do the same for the lateral malleolus by putting a posterior anti-glide plate to the lateral malleolus like this. We have special anatomical plates, locked plates, which can be used on the posterior surface of the lateral malleolus, like what is shown in the photo to the left. So what's next? Dr. Abdullah is writing lateral neutralization plate for the fibula. Okay, we have good questions here. Dr. Abdullah is asking if we can put the plate on the lateral surface of the fibula through the same approach. The answer is yes, we can do, but we need to extend our approach proximally and to retract the peroneal tendons laterally in order to be able to reach the lateral surface of the fibula. And yes, we can do it. And in this case, the plate acts as a neutralization plate if it's put on the lateral surface of the fibula, but if I put it on the posterior surface of the fibula like this, it is not a neutralization plate, it is an anti-glide plate. The other question is, if we can fix the fibula with the external fixation at the first stage, and the answer is yes, we can do. If the soft tissue around the fibula is not bad, we can go through fixing the fibula with putting the external fixator or the delta frame at the first stage. Yes, we mostly start with the fibula. If the fibula is comminuted, we can start with the tibia to restore the length. No, we mostly start with the fibula. If it is comminuted, we can put just a bridging plate to restore the length, and then we go to the tibia, to the posterior malleolus. So again, we change the position of the patient and we use an anterior or anteromedial approach in order to fix both the medial malleolus and the anterior chapeau fragment of the tibia. So this is after fixation. This is some sort of specific fragment fixation or fragment specific fixation for the distal tibia, in which we used like many plates in order to fix each of the fractured fragments of the tibia. This is not a must CT. We are only doing this for assessment of the reduction, but this is not mandatory, of course. I think the patient has done a lot of CTs and paying a lot of money in this case, especially. This was only done to assess the reduction of the articular surface like this. And we see here, if we look to the articular surface of the distal tibia, that it is well reduced and there is no step off at the distal tibia. Why we did this? Because we were comparing the step off at the distal tibia with the step offs that can happen in any other articular fractures, like the tibial plateau and like the fracture of the acetabulum. And this nice paper concluded that in the tibial plateau, articular incongruity is much more tolerated. And in the fracture acetabulum, restoring the weight-bearing dome of the acetabulum of the pre-injury decreases the post-operative, traumatic osteoarthritis. But in the distal tibia, we are not allowed for more than 2 millimeters step off, because more than 2 millimeters step off in the distal tibia leads to severe post-traumatic osteoarthritis, which may lead in the future to ankle arthrodesis. Dr. Ali is asking why it is important to repeat the CT after X-fix for any purpose. This is the most important CT. Now we have done for this patient 3 CTs. The most important one is the one that has been done after the external fixator, because our rule says span, scan, and plan. So this is very important in order to do our pre-operative planning. The question about diabetic patient, minimally invasive procedures. No, we don't use any minimally invasive procedures in diabetic patient. On the contrary, we do rigid fixation for diabetic patients, and we use more rigid plates, locked plates, and we prevent or delay weight bearing for double the period we do in normal persons. So if we delay the weight bearing for 6 weeks in a normal person, we delay it for about 12 weeks for a diabetic patient in order not to lose our fixation. Closure of the wound and post-operative care. We close the wounds and we do frequent dressing to be sure that there is no signs of infection. We remove the sutures about 2 weeks post-operative. Post-operative care is that we can start early range of motion for the ankle about 2 weeks after the operation, after removing the slab, but we delay weight bearing for at least 6 weeks after the operation. And then we can start rehabilitation and physiotherapy in the form of partial weight bearing and muscle strengthening exercise. Our take-home message is, sorry. Intra-articular fractures of the distal tibia is a part of high energy trauma mostly. Care should be given to the skin condition. First, start by spanning fixator. Post-spanning scan is crucial, and plan for the position and approach you are going to do, because failure to plan is, of course, a failure of fixation. Thank you.
Thank you, Dr. Amr, for this interesting talk. Any question for Dr. Amr? Thank you, Dr. Amr, for this interesting talk.
We have answered most of the questions. Thank you. Thank you.
Yes,
Thank you.
Thank you so much, Professor Amr Farouk, my dear friend, and
Thank
all
you.
our eminent guest speakers from Egypt, from UK, from USA, and from India, of course. Now our next speaker is my dear brother, Dr. Mahmoud Abu Zaid. Dr. Mahmoud will speak about subtalar instability. دكتور عمرو معايا بقى عشان حضرتك يعني معلش هنسلخه يعني. دكتور محمود يعني أخ عزيز وفاضل يعني يا فندم.
Thank you, Professor Ashab, our dean, our shining example, our shining role model. Thank you, Professor Ashab. I will talk about subtalar instability. it is a new item for ankle instability. This is a subtype of
Full
ankle.
screen, please, Dr. Mahmoud. Full screen, please, sir.
Okay. Our intending learning objectives is firstly to raise the awareness for subtalar instability. This is a new item and it is a subtype of ankle instability. There is some introduction of a new varieties of ankle instability like subtalar instability and terms as micro instability in ankle instability as gross instability for ankle, and we can see the diagnosis of subtalar instability and demonstrate the possible treatment modalities in cases of subtalar instability. This is a 29 years old male with history of road traffic accident 2 years ago and operated for fracture shaft tibia by interlocking nail. He presented with frequent ankle giving way, guarding with walking on uneven ground. So the chief complaint for this patient is frequent ankle giving way. On examination, there was an excessive subtalar range of motion with subtalar looseness and sinus tarsi tenderness with no obvious foot and ankle deformity, negative ankle anterior drawer, and the American Orthopedic Foot and Ankle Society score at the presentation was 64. We can see this patient. This is we can notice this rocking movement of the calcaneus again, but the patient complaining of giving way with negative anterior drawer test, and this is standing lateral X-ray. This is standing lateral X-ray. We can notice here the anterior displacement of the subtalar joint. The subtalar joint is not co-opted in the standing X-ray, so there is anterior displacement and an excessive anterior displacement of the subtalar joint. MRI of the patient, we look for the subtalar ligaments, which it's important to know the interosseous talocalcaneal ligament. This is an interosseous ligament between the talus and calcaneus, and this is the cervical ligament, which is anterolateral in order to the interosseous talocalcaneal ligament and the calcaneofemoral ligament. These three ligaments are the most important stabilizers for the subtalar joint: the interosseous talocalcaneal, the cervical ligament, and the calcaneofemoral ligament. And there is no consensus regarding the most important stabilizer for subtalar joint. Which ligament is the most stabilizer for subtalar? Is it the interosseous ligament? Is it the cervical? Is it the calcaneofemoral ligament? There is no evidence for the most important ligament. So how can I diagnose this case? The most important, you should do standing lateral ankle views. The separation of the posterior talocalcaneal facet more than 7 millimeter has been used for defined subtalar instability. And this is a golden rule, and it's very important to look for. Secondly, the ultrasound. The ultrasound has sensitivity about 94% and specificity reaching 91% for identifying the calcaneofemoral ligament. Also, we can use the subtalar arthrography and the MRI. MRI for calcaneofemoral ligaments is likely to be useful to define the true negatives, providing both true positive, as it can diagnose the associated injuries as osteochondral lesions, ligamentous stir, but it is as regards subtalar instability is of limited rule. The most emerging diagnostic tool is the weight-bearing CT. In this weight-bearing CT, you can see the subluxation in the posterior, middle, and anterior facets of subtalar joint and determines the degree of displacement in the subtalar joint and the degree of weight-bearing instability with this type of modality of CT. The treatment of subtalar instability, firstly, you should suspect this type of instability. You should look for, you should bottom line that there is an item called subtalar instability, which is totally different from the ankle instability itself, and this is one of the most important causes of recurrence in cases of subtalar instability. Firstly, you should try the conservative treatment in form of proprioceptive exercise, which is most important. The proprioceptive exercise is the golden physiotherapy for these cases of ankle instability and subtalar instability, with peroneal tendon strengthening exercise, with Achilles tendon stretching exercise. But when failure of these conservative treatment modalities for 6 months, you should go for surgical intervention. Surgical intervention for the failed conservative treatment options and may be done open or arthroscopic. There is no consensus which ligament has the priority for reconstruction. Is the interosseous calcaneal ligament, is the cervical ligament, is the calcaneofibral ligament? So in our modality of our surgical modality, we use those interosseous calcaneal ligament reconstruction with a tendon graft plus calcaneofibular repair with anchor tensioning. We can see this intraoperative video. Here you can see the excessive laxity of the cervical ligaments. This is too lax cervical ligament. You cannot see this too long cervical ligament in your operative cases. And this is the displacement of the posterior facet. This is a much excessive displacement of the posterior facet. And the laxity and overstretched cervical ligaments denoting subtalar instability. This is a reconstruction, but the general rule, we use fixation of the graft in the calcaneal tile with the biocomposite tenodesis screw, and the fixed graft in the talar tunnel with cortical suture button. We will see the X-ray photos, and this is the graft. We take a slip from the peroneus longus and do a graft for the interosseous calcaneal ligament, and this is the anchor to repair the calcaneofibral ligament. This is an intraoperative video after the interosseous calcaneal ligament reconstruction with repair of calcaneofibral ligament. This is the immediate post-operative standing X-ray. We can see this is the suture pattern over the head of the talus with an interference screw to fix the graft with the calcaneus here. And this is the anchor for calcaneofibral repair. And in this X-ray, we can notice the restored telonavicular cohabitation. This is the there is no anterior displacement of the posterior facet. This is the patient 6 weeks post-operatively, just after 1.5 months post-operatively. And in this 6 months period, the American Orthopedic Foot and Ankle Site score improved up to 82. This is 6 weeks post-operatively. The looseness of subtalar movement is improved much greatly. And this is 3 years post-operatively. This is 3 years after the subtalar instability reconstruction for interosseous calcaneal ligament and repair of the calcaneofibral ligament. and this is the maintenance of the cohabitation and realignment of subtalar displacement with no anterior displacement after 3 years. And this is the patient after 3 years. In this 3 years post-operative period, the American Orthopedic Foot and Ankle Society score became 94. Thank you very much.
Thank you so much, Dr. Mahmoud, for this very interesting presentation. أنا هسيب بقى الدكتور عمرو بيه فاروق معاك عشان هو اللي يعمل الدسكشن معاك يعني.
لا يعني thank you دكتور محمود for very interesting case الحقيقة. I heard it once before, but I think today it's a very clear message. It's a very rare case, but you have managed it in a very proper way. You went back to literature and you have done very clever techniques in order to restore the stability of the subtalar joint by using the peroneus longus for replacing the interosseous subtalar ligament, and something like a brostrom technique to repair the calcaneofibular ligament. I think it's a very clever and very nice case. Thank you, Dr. Mahmoud.
Thank you, Professor Amr. Thank you very much.
Any questions for Dr. Mahmoud about the case? Please write in the chat box if you have any questions.
Thank you.
My question to Dr. Mahmoud, يعني do you think about using something other than a slip from the peroneus longus as a graft for your ligament? Do you think about using something like gracilis or semitendinosus?
Yes, it can be done, and the lecture, some papers use gracilis for reconstruction of the interosseous calcaneal ligament, but in this case, the Peroneus longus slip introduce is less incision, and this is a single incision, not other comorbidities. Is a single incision. We can use this slip for reconstruction without any other site surgeries.
Dr. Abdullah is asking you if all the subtalar dislocations will lead to subtalar instability?
No, subtalar dislocation definitely have a subtalar ligament impairment and functional affection, but not all subtalar dislocation can lead to functional instability. It is importantly you can look for the instability and giving away the patient and particular examination for the patient, not for the MRI or X-ray finding only.
Fine. So if we do proper reduction for the subtalar dislocation, the ligaments can heal without leaving any subtalar instability. Okay.
Especially with the physiotherapy program, which starts with proprioceptive exercise and strengthening exercise for the Peroneal, this lead to functional improvement.
Thank you, Dr. Mahmoud. I think we can go to the next speakers.
Thank you, Dr. Amr. Thank you, Professor Amr Farouk. Thank you very much. Professor Ashhab. Professor Muhammad. We are waiting for the next talk.
Okay, until Dr. Ahmad Ikram is ready, we can.
Dr. Ahmad Ikram will not join us.
Okay.
We apologize for for joining us today.
Dr. Ahmed Ikram is not joining.
Yes.
Okay. Then we have Dr. Muhammad Hashim from United Kingdom. About
هو احنا عندنا a little bit problem. هو دكتور محمد هاشم في ايده عمليه قدامه 10 minutes، وكذلك بروفيسور فينو، دكتور فينو from UK، ودكتور كريم من امريكا بيصلوا الجمعه دلوقتي في امريكا. فهم الثلاثه كلهم قدامهم just مثلا 10 minutes ويجوين معانا.
طيب if you like I can give a rapid case presentation in this 10 minutes.
Please, sir.
Let me check. Yeah.
Please, sir. Yes.
Okay, this is another Pilon, another case about Pilon fracture, but this time in a diabetic neuropathic patient. So we can go rapidly through it in just 10 minutes. Our learning outcomes is to recognize the Pilon fracture and how to deal with it in neuropathic patients, and to try to put a treatment strategy and identify different methods of fixation. So this is a 62 years old female who is diabetic. Hemoglobin A1C is 8.5. On examination, she is having mild peripheral neuropathy. She fell on the stairs. My question to all of you is, any concern about these conditions that the patient is diabetic? Hemoglobin A1C is 8.5 and she is having peripheral neuropathy. Does it make any change in my decision or in my method of treatment? Sorry. Trying to check the chat box. Where is the chat box? Yes, it can go to Charcot, go to rigid fixation, locked plates. Yes, you are correct. Of course, we follow the same rules like what we have said. CT is mandatory in such a patient, and this is our CT showing that there is lateral malleolar fractures and there is a comminuted fracture of the distal tibia. We can see the fractured fragments like this. There is a posterolateral fragment, there is an anterolateral fragment. So Is there any other options? Yani, what do you choose now to do? You go for fixation, as we have done in the last case, or maybe you have another choice. Yes, Ahmed Ali is writing arthrodesis, and Dr. Ayman control diabetes. Yes. Do you think we can go directly to the operation room right now while the hemoglobin A1C is 8.5, or I have to delay the surgery? Hemoglobin, Dr. Ayman is saying, Ayman is saying is hemoglobin A1C just must be below 6. طيب يعني I have to wait for a lot, maybe several months until my blood glucose is adjusted. And this is an emergency case. This is a trauma case. So, let's see what happened with this patient. She she went to one of the very clever surgeons, and she had this treatment. A fragment specific fixation, as we have said, fixing every fragment with locked rigid plates, and it seems that the fixation is good, and it's clear that he has used the same approaches, a posterolateral approach and an anteromedial approach. Do you think something is bad about the fixation? Do you like the fixation? The problem about neuropathic patients is that they don't feel pain, and you have to insist on delaying weight bearing for maybe double the normal period for normal persons. So you should insist on that, because most of these patients are not feeling the pain after the surgery and are tending to walk on their legs. So this is the very dangerous thing about this. So although the patient had a very good fixation, yes, Dr. Ahmed Khairi is telling many hardwares. صح, you are correct. This is too much hardware. So what happened is, unfortunately, this is another CT which was done for the patient after the operation to assess the reduction. It seems that the reduction is good and the articular surface is good. So it failed few months after the operation. Why it failed? Because of the non-compliance of the patient. The patient started weight bearing without telling her surgeon, and this is what happened right now. Maybe because, as you have said, the hemoglobin A1C wasn't optimum, and because she was non-compliant. Okay, let's go because I think we are ready with the next speaker. So we go rapidly through the case. Although this was the first lateral view was good, this is after failure. The first anteroposterior view was good, this is after failure. So what was done is that she went to another surgeon, which took everything out. All the hardware was taken out, and this is what the condition is right now. So later, after the second surgeon thought that there is no infection and ESR and CRP are getting good, so he took her again to the operation room, and he has done this calcaneotibial nail for her. What is your comment about this arthrodesis or trial of arthrodesis? I think we are now dealing with like something like a Charcot patient. He removed even the lateral malleolus completely, and it seems that the nail is not centralized in the talus. Dr. Ahmad Hassan is saying that pan-talar arthrodesis, it's not a pan-talar, but it's subtalar and ankle arthrodesis, but it seems that the talus is not centralized under the tibia, and the nail is going in a wrong pathway. So unfortunately, this is what happened later on after the patient starting to weight bear once more. So it's becoming more complicated. What should be the next step? Again, everything was taken out and cultures were taken, and we couldn't do much more fixation in this step due to infection. Of course, patient had antibiotics, and we followed her up in the form of ESR and CRP, and then I referred her to one of my colleagues that is doing Elizarov external fixation, like what you have said, and this is how it ended, by removing part of the segments and shortening using an Elizarov frame like this. So our take-home message is pilon fracture in neuropathic patient is a separate entity, and philosophy is of management is different. Augmented fixation is recommended with rigid plates, and delaying weight bearing is very important, Most patients are non-compliant because they are not feeling pain. Elizarov is a good salvage procedure. Thank you.
Thank you so much, Professor Amr Farouk, for your interesting case presentation. Our next speaker will be Mr. Vino Caverthepo from UK. Mr. Vino will speak about diabetic foot reconstruction. Thank you so much for being with us, sir.
Good evening. Thank you very much for this invitation and for this opportunity. I would like to take you through diabetic foot orthopedic surgery, as I've been asked to cover this topic. Again, you have an amazing range of topics. Well, I run the orthopedic component of the largest diabetic foot surgical MDT service in Europe at King's College Hospital in London. However, who should be the lead surgeon in a diabetic foot surgical multidisciplinary team? It is so variable globally. In US and in some other countries, it is often a podiatric surgeon or a foot and ankle orthopedic surgeon. In some countries, it is a general surgeon. And of course, in some countries, vascular surgeons. In some healthcare organizations, it can be a plastic surgeon. In fact, in Italy and in some other places, even endocrinologists provide such type of surgical cover. And an orthopedic surgeon is getting perhaps increasingly involved in the surgical management of the diabetic foot and taking the leadership as well. And that is still evolving. But if you look at all diabetic foot surgical conditions we're expected to address, they can range from simple apical to ulcer or lesser toe deformities or hallux deformities, rigidus, or other forms of deformities, prominent first metatarsal head plantar was due to overactive peroneal longus leading to ulceration, or all forms of ulcerations with or without bone infections. There can be minor soft tissue defects from that infection process, or even major soft tissue defects following, as an example, a diabetic foot attack. Ulcers with minor deformities in combination with ulcers or major deformities such as a Charcot foot, a diabetic foot attack, necrotizing fasciitis, microvascular disease and macrovascular diseases, neuromuscular deformities mainly due to the neuromuscular imbalances, or a deformed Charcot foot, or even foot and ankle trauma. There's such a wide range of diabetic foot surgical conditions a surgeon in an MDT should be able to address. So if we can categorize the perhaps common procedures for all surgical specialties, ulcerations, infections, minor deformity, minor soft tissue defects, no matter whatever type of surgeon you are in that MDT, should be able to cover those aspects. But if there's a significant vascular or endovascular pathologies, then a vascular surgeon. Similarly, major soft tissue defects cannot be perhaps delivered by other surgeons. And similarly, for orthopedics, a major deformity such as a Charcot foot or neuromuscular deformity with or without instability, or more recently, microvascular deficiencies and diabetic foot and ankle fractures as well. So it is very clear that as an orthopedic surgeon in such a team, we will be dealing with all these orthopedic major presentations, and also a common competencies that deal with routine and minor presentations that are common to all surgeons. So to summarize, an orthopedic surgeon in a diabetic foot service covers all these conditions I have just enumerated here in this additional circle. So keeping that in mind, perhaps if I could take this opportunity to let us review these orthopedic aspects of diabetic foot surgical presentations. And the commonest one is dealing with diabetic foot ulcers. And that ulcer can be predominantly due to vascular deficiency. Of course, those should go to a vascular surgeon. But those with infection and mechanical origin should be expected to be managed by an orthopedic surgeon. And that management involves doing, achieving the infection control, mechanical control, and biological control. But I'm going to emphasize the surgical component of that infection control, which is the surgical debridement. And, as orthopedic surgeons, we are super experts in that area. And certainly for a diabetic foot ulcer, that is the most important key intervention that influences not only the immediate, but the long-term outcome. And the aim here is to achieve infection eradication, not just control. And also, if there is any underlying pathology that has contributed to that ulceration, predominantly ischemia or mechanical abnormalities, those need to be corrected as well. Otherwise, the ulcer doesn't stay healed. So this is a very common presentation, a diabetic foot ulcer. If that requires debridement, we can observe that these ulcers come with a zone of necrosis, clearly infected, very obviously pathological tissue, necrotic tissue. But if you observe, that is surrounded by a zone of granulation tissue or scar tissue, which we call it a reactive zone. And outside that zone is normal healthy tissue with no infection, no such scarring at all. So this case example, small ulcer, diabetic foot ulcer, multiple recurrent ulcerations with multiple infections in this particular example. And our regular surgical training has debrided that ulcer, and that looks reasonable. But unless if you extend, do proper examination, on this occasion, it's required quite significant extension of that incision to assess this large area of underlying reactive zone. And that reactive zone harbors pockets of infection. Unless if we physically remove that, there is a very high risk of infection recurrence. So you remove all of that so that you reach the green zone, and then the chance of ulcer healing is much, much higher. So, and we have described this technique and its effect on our outcomes about a decade ago. But I just want to re-emphasize, and I'm sure that all orthopedic surgeons in the panel and the delegates that have joined do that, but we'd just like to remind ourselves, again, this particular presentation, a diabetic foot attack, originally managed at the local hospital with these smaller surgical debridements, that doesn't work. All of that necrotic damaged skin tissue requires physical removal. And again, further subsequent debridement as needed, as it was required on this occasion, with simple bedside debridement and VAC therapy until the granulation tissue and then skin grafting. But however, this foot is deformed. Unless if we correct the deformity, the risk of recurrence, or more importantly, new ulceration is very high. So any associated exostosis or osteomyelitis needs to be excised, and any dynamic or static deformities need to be corrected. Then only you can prevent new ulcer formation or recurrence of ulcers. So how about those ulcers with a dynamic deformity? There are many forms, but the commonest one is very tight Achilles tendon or gastrocnemius. And if those are managed with gastrocnemius recession or Achilles tendon release, depending on where the tightness is, again, these non-healing plantar forefoot plantar ulcers respond very quickly. And we, at our unit, King's College Hospital, we have two minor procedure theaters within the clinic complex. And when the patients come with these presentations, we do percutaneous tender Achilles lengthening using Hooke's technique there and then. And then the patient goes into a full total contact cast and commence full weight bearing. And after 6 weeks, we discontinue the casting. And usually by that time, the ulcer heals. Another common pathology is peroneus longus or overactivity. Again, the neuromuscular component of a diabetic foot quite often results in overactive peroneus longus that leads to recurrent ulceration and you can, in this plane, you can see that the first metatarsal head is plantarly prominent. Again, we perform these procedures in our clinic minor procedure room, identify where you make the incision to access the peroneal tendons. You can see from the contracture of the tendons the exact location. Under local anesthetic, identify the longus and brevis, and longest one, we know the anatomical location, but if we need to, we will check by seeing its action. While the longus is under tension, suture the longus and brevis together first, and then release the longus tendon. And that leads to immediately observation of the metatarsal head prominence reduced. And even when you perform minor amputations, as orthopedic surgeons, we should be aware of the associated deformities that need to be corrected there and then to correct the deformity or even to prevent deformity. When we do a transmetatarsal amputation, the risk of equinus contracture is very high. So we very routinely do the tendon balancing procedures at that same time. On this occasion, the tibial anterior location is readjusted, Achilles tendon released to prevent equinus. We use the extensor tendons because the motor units are still functional and suture them to the periosteum at the base of the metatarsals in optimal tension. Again, not only for tenodesis effect, but also to provide dynamic control. And on this occasion, to prevent infection, recurrence, progression, we use one particular product called, it's an antibiotic-loaded injectable calcium sulfate hydroxyapatite preparation called Surament. And again, so that is, we as orthopedic surgeons are really able to deal with all of these. Which may not be practical, skilled by as an example, vascular surgeons. So here, the muscle tendon function are preserved, and any associated dynamic or even static deformities are corrected. But however, those ulcers that are associated with fixed deformities, often due to Charcot foot or sometimes neuromuscular foot, unless if you correct the deformity along with the ulcer debridement, you cannot get the ulcer healed or stay it healed. And this is a typical example, not an actively infected ulcer. For those presentations, we do as a one-stage procedure, debride the ulcer, redrape, and then proceed with Charcot foot reconstruction. Again, because you have corrected the deformity, you have achieved stability, the ulcer heals and it stays healed. And the patient also achieve good ambulatory status. So those major deformities in the diabetic foot setting are either predominantly neuromuscular, can be a K-virus type presentation. It can be flexible in early stages, or partially rigid or completely rigid. Or more often, a Charcot foot, which can be in the active phase, active Charcot foot, or chronic inactive phase, inactive Charcot, and again with or without ulcerations, and it can be rigid or unstable to mobile. So there are so many possibilities. So if you look at the neuromuscular deformities in this particular patient example, a very severe hindfoot varus, forefoot adductions, and again fixed supination deformity. And again, on this occasion, a hindfoot reconstruction. Again, when you perform a hindfoot reconstruction in neuromuscular deformities, it is really critical, or any reconstruction, that we achieve tendon balancing at the same time. And again, it's not a perfect deformity correction, but it gives stable, weight bearable foot. But this one example is more of a very severe hindfoot plus midfoot Charcot deformity, again with significant neuromuscular component. Using the same principles enumerated, we perform a combined hindfoot plus midfoot Charcot reconstruction that provides permanent correction through bone fusion, and the patient can regain full ambulatory status. Whereas the Charcot foot reconstructions, again, they come in so many permutations and combinations, and those accordingly are managed with internal fixation Charcot reconstructions. But on some occasions, external fixations can be used. That is, in our practice, I'm sure that different centers have different ways of dealing with this. So in this case example, where the medial column is predominantly affected, we usually reconstruct these using what we call a beam and a locking plate as well on the top. And this was one of my first midfoot Charcot reconstruction on a staff member, colleague in the hospital. Again, she has been very mobile even after 8 years with no ulcer recurrence. So that is a simple midfoot Charcot, and similar principles are applied for a hindfoot Charcot. So the principle of fixation for Charcot reconstruction using internal fixation should be a long segment and rigid internal fixation in optimal bone position. So an acute hindfoot Charcot with an unstable hindfoot deformity corrected during the surgical procedure and reconstructed using this long segment and rigid fixation, and that requires an additional calcaneal tibial screw. And we have published all these surgical techniques and the outcomes, including the rates of unions and metalwork failure. And by and large, when you do a hindfoot reconstruction, if you achieve isthmus fit, and if the medial malleolus is left intact, and if you use an additional calcaneal tibial screw, which provides additional rotational rigidity, the risk of metalwork failure and non-unions are minimized. So another Charcot foot with combined, again, significant medial and lateral column deformity. We do wedge resections to correct the deformity to line up the medial and lateral columns. And then once you're happy with the degree of the correction through wedge resections and soft tissue releases, stabilize using beams and plates. And in major deformities, it is critical that soft tissue balancing is achieved by doing the tendon realignments as well. Again, this patient is also very long-standing. But how about actively infected Charcot feet? And such as this one, an acute Charcot, this is in stage 2 Eichenholz disease, but because of the instability and deformity, infected ulceration. So those are managed with staged reconstructions in our unit. In the first stage, you do aggressive debridement using the principles I have mentioned to you earlier, using that red, amber, green zone principles. Do the bone resections as well to correct the deformity, and then reach the corners. And once you are satisfied with the full synovectomy and debridement, and then fill that gap with an antibiotic-loaded calcium sulfate preparation beads. Again, fill them nicely, and then provide stability. For that, we use 3 guided wires. Then that ulcer starts healing very well. Swelling reduces. Sugar control is optimal. CRP comes down and stays down. And then, after 6 to 8 weeks, you take the patient back to theater and do the second stage. Here, prepare the bone surfaces again and reconstruct using the principles I have enumerated. So by performing a good surgical debridement and providing local antibiotic elution as well as other measures, one would expect to have achieved an infection eradication so that you can do this second stage reconstruction well. But more recently, we have been involved in managing these type of pathologies where ischemic Charcot foot with a no option ischemia, what the vascular colleagues describe, and we have a very aggressively active vascular unit, and they do below the ankle bypasses and endovascular procedures very routinely, but sometimes it is not possible. And in this patient who had a transmet amputation on the other side, on the left side, but with chronic non-healing right midfoot ulcer and Charcot foot. And we have decided to go through limb salvage procedure because he's a young patient, 46. And we use this principle of TTT, transverse tibial cortex transport, which has been very, very well established in treating ulcers, diabetic foot ulcers, mainly popularized in China. But we wanted to apply the same principle to achieve bone fusion as well. So yes, done the reconstruction, then we applied the frame to do the tibial cortex transport, distract, and again compress back. Again, to our pleasant surprise, there is abundant callus formation, even though it was described as a desert foot by the vascular team, and many studies are coming through. So this was the first Charcot foot reconstruction reported using the TTT technique. How about young patient, this 33-year-old young patient with severe talar body avascular necrosis as a part of the Charcot process? You can do a calcaneal tibial fusion, why not? But it is possible to maintain the leg length, particularly in the young people. It is good to maintain the leg mechanics. So we use the 3D printed titanium cage called Meshworks, and you pass a hind foot nail through it and then correct the midfoot as well. And majority of the combined hind foot plus midfoot reconstructions take about 4 to 6 months before they can walk in the cast. But in this patient, I was able to commence full weight bearing much sooner. So again, first such procedure performed for Charcot foot reconstructions that has been again published. So just to remind ourselves, friends, the role of an orthopedic surgeon, which is very much getting established, it is still evolving, is to address all these pathologies. So we should possess the core competencies in all areas, basic level of knowledge and skills on the medical, wound care, podiatry, offloading, vascular and plastic surgery, but acquire advanced knowledge and skills in these complex tasks, such as tendon transfers, complex deformity corrections, foot and ankle trauma, microvascular correction procedures, which is evolving. So it is felt that an orthopedic surgeon, if has a component of vascular skills a bit, and plastic surgical skills as well, and that can perhaps make that foot and ankle orthopedic surgeon a full-fledged diabetic foot orthopedic reconstruction surgeon. And this editorial was done by a colleague and me, and in fact, that journal editor, Dr. Shaw, is also in the group here. So what we'd like to emphasize is that, there is a massive shift towards increasing towards an increasing role of an orthopedic surgeon in a diabetic foot multidisciplinary foot team globally. And I think it is critical that those that are interested in trying upskill themselves to be able to deliver such complex care. Those of you who like to learn more about shock of foot reconstructions, all diabetic foot surgical reconstructions, and the surgical multidisciplinary care of a diabetic foot, I would like to welcome you all. Consider attending the next King's College Hospital annual symposium. And again, with that, I would like to thank you for giving me this opportunity to share our experience. Thank you, sir.
Thank you so much for being with us, Dr. Vinio. It was an honor for us, sir. Thank you so much, sir. Dr. Mahmoud, if we have any questions to Dr. Vinio?
Any questions? No, sir. Thank you, sir.
Thank you so much, sir. Thank you so much. Dr. Mahmoud, I think our next speaker will be Dr. Muhammad Hashim. Dr. Muhammad, you are with us? دكتور محمد هو اتصل بيا، هو معانا بس اعتقد هو داخل اتندي مش باناليست.
أنا يا فندم تمام.
تمام.
دكتور محمد هاشم.
Yeah, hi, Dr. Mahmoud. Sorry, I joined as an attendee, so it didn't give me a chance.
Yeah.
How are you?
I'm fine. So, am I ready to go?
Muhammad will... Dr. Muhammad will talk to us about the Peroneal tendon pathologies.
Can you see my screen, Dr. Mahmoud?
Yes, yes, sir.
Yes.
Okay. Good.
Full screen, Dr. Muhammad.
Full screen.
Thanks for the invitation. Thanks, Professor Ashab and Dr. Abu Zaid for this chance to speak to you today about peroneal tendon pathology. Actually, I will shed a quick light on this a bit dark area of practice for foot and ankle, especially for juniors. So peroneal tendon pathology is one of the areas which is not fully covered in orthopedic practice, in foot and ankle orthopedic practice. My name is Mohammed Hashim. I'm a foot and ankle consultant in Northwest London, Frimley Health NHS Trust, and I'm a Royal College faculty. So speaking about the peroneal tendons, we will follow these points when we're discussing the peroneal tendon pathology today. So we'll speak about anatomy, variations which related to peroneal tendon pathology, function of peroneal tendons, what's the etiology of peroneal tendon pathology, what contributes to peroneal tendon pathology, and what types of pathology we see with the peroneal tendons. We will focus on the tenosynovitis, tears, subluxation, and dislocation. We'll speak about the clinical signs, investigation, and treatment algorithm, and I will show you my approach to peroneal tendon pathology treatment. So when we speak about the anatomy, there's quick areas which we need to focus in when we speak about the anatomy. So we know all that peroneal tendons are coming from the back of the fibula, interosseous membrane, and the tibia. They pass into the retromalleolar groove, and they go below the lateral malleolus. So the peroneus brevis inserted in the base of fifth metatarsal, and the peroneus brevis goes in the peroneal groove going to the base of first metatarsal and medial cuneiform. There is a zone of vascularity, which we will show you in a minute. We need to speak about the peroneal tubercle, the cuboid groove, and the os peroneal. When we speak about zone of avascularity, which as you can see here is the area where the tendon turns around the bone in the retromalleolar groove and around the tip of the lateral malleolus. So there are three zones where the tendon's blood supply is not the best. So the blood vascularity to the tendon is not the greatest area. That's why it's the commonest area to have pathologies, especially tenosynovitis. When we speak about the peroneal tubercle, it's a bony prominence, as you know, at the lateral border of the calcaneum, where the peroneus brevis pass above and the peroneus longus pass below. And when we have calcaneal fracture, it's a common area of peroneal tendon pathology and pain. Cuboid groove under the cuboid, where the peroneus longus runs across the midfoot, reaching its insertion in base of first metatarsal and medial cuneiform. It's again area of pathology, especially an area of avascularity, zone of avascularity for the peroneus longus tendon. And lastly, the os peronei, as we all know, is a sesamoid bone in the peroneus longus tendon, and it's a common area to have an inflammation and pain. So os peronei, as you can see, which is always missed as one of the common causes of lateral ankle and foot pain. So it's a sesamoid bone in the zone of an area of zone of avascularity of peroneus longus, and not uncommon to have pain from os peronei. So what anatomical variations we see which participate in having a peroneal tendon pathology? So the first and the commonest of them is the lower belly of peroneus brevis. And as you can see, it's common up to a third of the patients which will have a lower peroneal or a lower belly of peroneus brevis. It's very, very common that when you open a lateral malleus for a fixation of fibula, you see that the belly of the peroneus brevis is continuing up to the retromalleolar groove. We cannot frankly understand the pathology behind it, but what we know is it makes a compartment, the peroneal compartment, especially under the superior peroneal retinaculum, a bit tight, and it causes a lot of pathology and pain at this area. It's again one of the participating factors in subluxation and dislocation of the peroneal tendons, and sometimes or commonly to be asymptomatic in a lot of patients. The second variation is to have an extra muscle, which is the peroneus quartus. And as you see, the peroneus quartus is commonly to come from the posterior surface of the peroneus longus and the back of the fibula, and it goes either before the superior peroneal retinaculum or it goes up to the peroneal tubercle. It's a lot of variation of the peroneus quartus, but again, it's one of the causes of tight peroneal compartment, peroneal pathologies, especially tenosynovitis and peroneal dislocations. So it's not uncommon. It's about 27% of the population will have a peroneus quartus. Again, it's one of the causes of lateral ankle pain. It leads both to peroneal dislocation because of the tightness of the peroneal compartment. When they examine MI scan of 80 patients with lateral ankle pain and problems, they always find with peroneus quartus adheres in the peroneus brevis and subluxation. The good side of it that we use it sometimes as a graft to repair the superior peroneal retinaculum. If we come to the function of the peroneal tendon, so as we understand, both of them are plantar flexors because they pass behind the center of rotation of the ankle. For the peroneus brevis is the principal everter of the foot, and for peroneus longus is the main plantar flexor of the first ray. There are two important rules the peroneal tendons play, which we always ignore. The first one, they do a proper muscle balance around the ankle. So tip post is balanced by the peroneus brevis, and tip ant is balanced by peroneus longus. And if we miss this peroneal for any reason, tenosynovitis, tears, or ruptures, we lost the balance, the muscle balance around the ankle, and we have a problem with the ankle position. The second thing is they play a vital role in the dynamic stability of the ankle. So the lateral ankle stability doesn't depend only on the lateral ankle ligaments, but as well on peroneal tendons as a dynamic stabilizers. So why we have peroneal tendon pathologies or pain? Some of them is just an overactivity. So people who are doing special sports, especially the dancers, the runners, especially if these runners do a long distance and with turning sports, snowboarding, all these activities is an overstress over the peroneal tendon. So it's not uncommon to have peroneal tendon pathology with such sports. Second thing is very commonly to see this in a tight calf muscle. That's why it's very advisable if you see a patient with peroneal tendon pathology or you suspect a patient with peroneal tendon pathology to have a look on the patient dorsiflexion and extension and do a Silver's coil test, because not uncommon to find that this patient has a tight calf muscle. Definitely, if the patient has any predisposing or background of a muscle pathology, like the patient have fibromyalgia, the patient have some sort of myopathy or whatever. So any underlying muscle pathology or muscle problem generally in the patient will be a predisposing factor for a peroneal tendon pathology. Third thing is abnormal alignment or biomechanics of the ankle and foot, especially base cavus and base planus. So with base cavus or base planus, our problem is that the whole mechanics of foot and ankle has changed. So subtalar joint and others are, and position of subtalar joint, position of ankle joint has changed. So there is overstress on the lateral aspect of the ankle, and this predisposed to a peroneal tendon pathology. Definitely, if we have an ankle tendon, ankle instability, peroneal tubercle hypertrophy, calcaneal fractures, severe ankle sprains, all this means we lost the lateral ankle ligaments, and so the peroneal tendon will be under stress. How will you see this patient with peroneal tendon pathology? It's definitely the main and the clear symptom will be pain. This patient will come with a lateral ankle pain. Lateral ankle pain has a big differential diagnosis. One of them, we have to keep in mind that peroneal tendon pathology is one of the common causes of lateral ankle pain. We always treat the lateral ankle pain very lightly. It's just an ankle sprain, give the patient some form of support and analgesia and physiotherapy and go. But I promise you, it's not always benign. So you need always to have a look in the ankle pain, analyze the lateral ankle pain, keep in mind that peroneal tendon pathology could be the cause, have a look, examine the patient, and exclude peroneal tendon pathology as one of the causes. So after pain, you may find that there is some fullness or swelling. You might have some snapping, a patient complaining of some clicking and snapping at this area. Definitely instability if the tendons are just popping out from the retromalleolar groove, and if there is a frank subluxation or dislocation. So as you can see, so in this video underneath, you see that the patient has global ankle instability, anterior draw and varus inversion. On this picture, you can see easily that the patient has some fullness in the back. So this patient has, as we agreed, some malalignment and base cavus, which predisposed to the problem. And this patient has a frank dislocation of the peroneal tendons coming out from the retromalleolar groove to the lateral malleolus. So the signs will be, as we see, fullness, abnormal ankle position, instability, weakness, bony protuberance if the protuberance if there's a hypertrophy of the peroneal tubercle, subtle base cavus or malalignment of the foot. That is very easy to spot that the picture on the right side shows a weak peronei. So as you can see, patient is doing pure eversion, and with weak peronei, the eversion is very weak in this side compared to that side, and it's very advisable to compare the both sides to spot there is a weakness in the eversion. So what pathologies will the peroneal tendon have? So as commonest for all the tendons to have tenosynovitis, tendinosis, and tenosynovitis, especially if the patient has a background of inflammatory disease, especially rheumatoid, subluxation or dislocation, and commonly to have an intrasheath instability as one of the underlying diagnosis, and lastly to have tendon tear or rupture, and this is commonly with malalignment or instability. So if we come to tenosynovitis, you can see that it's commonly, as we agreed, in repetitive sports activity, especially strenuous sports like running, like dancing. Definitely if the patient has a background of rheumatoid inflammatory pathologies, and thankfully now the disease-modifying agents and medical treatment has solved a lot of this problem. MRI scan will be the best way of diagnosis. As you can see, you will see a very clear signal change around the tendon and fluid collection. And the main treatment will be conservative treatment in the form of activity modification, give the patient a period of rest, analgesia, orthotics. You may offload this patient with a boot or plaster, even if the patient is in acute pain, and you may end by doing tenoscopy. As you can see, is just a clinic-based procedure with 2 holes over in the tendon sheath. Go and have a look in the tendon, see the tendon running, get any adhesions out, and treat any pathology you can see. Subluxation and dislocation, and as we agreed, is either there is a foot malalignment or there is an ankle instability. So the patient is always exposed to inversion injuries. And if he has an inversion injury with sudden contraction of the peroneal, they end by subluxation or dislocation. So they either bob or snap out of the retromalleolar groove, especially if the superior peroneal retinaculum has gone. So if you dorsiflex and circumduct, you will see the tendons subluxing or dislocating according to the degree of injury of the superior peroneal retinaculum. It's not that rare. So about 0.5% of ankle injuries in USA is subluxation or dislocation. Definitely, the patient may have some underlying factors. So if the patient has a shallow fibular groove, as we agreed, if have anatomical variation like low-lying peroneus brevis belly or peroneus quartus, or if the patient have a structural deformity like a base cavus. So as you can see here, just the peroneal tendons are bobbing out of the retromalleolar groove. Once the patient is relaxed under anesthesia, I push it back in the retromalleolar groove. Once I remove my hand, it bobs out again. And this is, you can see visually. So there is no superior peroneal retinaculum. Nothing is maintaining the tendon into the retromalleolar groove, and they just simply sublux out. So as you can see, so a lot of types of dislocation or subluxation. Many classifications has prescribed this, starting from just an injury to the cortex, just elevation of the cortex, to loss of the fibrocartilaginous disc, then to complete subluxation, then to rupture of the superior peroneal retinaculum from the calcaneum side, and complete dislocation of the tendons. How to diagnose the subluxation? So definitely X-ray will show us easily some avulsion fracture. If there is an avulsion injury to the superior peroneal retinaculum, you can see if there is a deformity, if you can see if there is a shallow groove. CT will confirm this, and ultrasound is a dynamic examination, so you can easily spot and see while dynamically moving the ankle, how the peroneal tendons are bobbing in and out. And MRI scan is definitely the best way of diagnosis. Will show us the superior peroneal retinaculum problem, if the superior peroneal retinaculum has gone, and will show you clearly the tendons problem. X-ray, as you can see on the left side, so as you can see, there is a bit of avulsed fragment here, confirmed on CT. And definitely, if you have a look here, there is a very shallow groove. And as you can see, the tendon already dislocated lateral to the lateral malleolus. The common variation of subluxation or dislocation of the peroneal tendons is to have an intra-sheath subluxation. With intra-sheath subluxation or snapping, as you can see, is firstly prescribed in 2006. Then Reckon has classified it in 2008. And it was the patient come with pain and clicking, but there is no clear dislocation of the tendon. Tendons are still in place. It's just the patient have the feeling of pain or clicking. And as you can see, there is a big split in the peroneus longus where the peroneus brevis bobs in and out. So still the superior peroneal retinaculum is intact. And the way to diagnose this is the MRI scan will show you a split in the peroneus longus tendon, but you have to have a dynamic ultrasound to show you how the peroneus brevis is bobbing in and out the peroneus longus slit. So, and how can we deal with subluxation or dislocation? So on a spot, when the patient have an injury to the superior peroneal retinaculum ending by subluxation or dislocation, you can firstly just immobilize this patient in a plaster or a boot. But you need to understand that immobilization alone or conservative treatment alone will carry a high risk of failure, about 50%, because basically this is a mechanical problem. So it needs some sort of surgical treatment. So operatively, how we treat this? So firstly, if just the problem is in the superior peroneal retinaculum, we repair it or tighten it or double press it or anchor it to the bone. If the problem is in the peroneal tendon itself, so we repair the peroneal tendons. And with the repair of peroneal tendon and superior peroneal retinaculum, if we have a bony problem of shallow retromalleolar space, we have to do a demon procedure to make a retromalleolar groove. And at the end, if we cannot maintain the stability of the peroneal tendons with any of this, the option we have will be a blocking procedure, something like Chiari osteotomy as a salvage procedure. All what you need is to get it right first time and choose the right operation for the right patient. So as you can see here, just simple superior peroneal retinaculum repairs. We just get the ends of the superior peroneal retinaculum to each other. Commonly, we have that in an acute setting when just is acutely injured. At some point, you cannot get it repaired because it avulses from the bone. So the other option is to put a couple of anchors and repair it at two different levels, just to get the superior peroneal retinaculum back to the fibula so maintain the tendons in place. As you can see, once you repair the superior peroneal retinaculum properly and at 2 levels, the peroneal tendons are very stable inside. So sometimes all the evidence is supporting to do some deepening procedure with superior peroneal retinaculum repair, and this yield the best evidence and the best results. So a lot of options to deepen the procedures, maybe just minimal drilling through the retromalleolar area, so to create a more or deep retromalleolar space. May you take some piece of bone with the burr and then push the cortical bone back after you clear the endosteal. You may use, as you can see, this is where we use the burr. So we just get the tendons away, and then we go with the burr and we just deepen the groove inside as much as we need to get the peroneal tendons stability. As you can see here, you may go to do this deepening procedure. So in basic terms, you go with an osteotome, then cut this piece of bone, get it out, clear the endosteum until you be sure that you will maintain a deep groove, then push the cortical bone back just to keep it smooth for the peroneal tendons to run, and then you have a deep groove. As you can see here, we just with oscillating, so we go take piece of bone, then after we make a slider of bone, we clear it with a Walkman spoon, and then as you can see here, we just push the cortical bone back, so we make a small bit for the peroneal tendons with a deeper groove. Bone blocking procedure is some sort like cariosteotomy in the pelvis. So if all this fails, the only option is to get a bony cover for the peroneal tendon. So we just get a slider of the bone of the posterior fibula and make it like a bone shelf or a bone block to stop the tendons from dislocating. So it's a sort of salvage procedure. So what the evidence says. So if we have a look in, most of this evidence is coming from the States, especially from New York, from Hospital of Special Surgery. And as you can see, all the evidence is pointing that using a deepening procedure with superior peroneal retinaculum repair yields a better results, less redislocation, and a higher satisfaction rate. This next study has looked into the wound dehiscence and reoperation. And they can say that the reoperation and wound dehiscence is less with the bony procedure, surprisingly, is not with the soft tissue. So if we come to the third pathology and the last pathology is to have a split tears or ruptures of the tendons, which is mostly because of dynamic abnormal alignment of the hind foot or ankle instability, which put a lot of stress on the peroneal tendons, ending by peroneal tendons tear and ruptures. So if the tendon is to keep recurrently subluxing or dislocating, SPR is gone, ankle is chronically unstable. So 30% of these patients will have a peroneal tendon tears. If patient has an anatomical variation like a lower belly of peroneus brevis or peroneus quartus, especially if the patient have a bis cavus with a lot of stress on the lateral ankle structures, so the tendon will be teared or rupture, and commonly it is the peroneus brevis tendon, 88% compared to peroneus longus. Sometimes they are both tendons injured at 38%. So if you have a look here, you can easily spot that the longus is running, but the brevis has already gone. And as you can see here, there is a fullness in the back, and if you put your hand, you will feel the patient will be painful there. If you have a look here, so the artery clip is going through a slit in the peroneus longus, and this needs to be repaired. Algorithm for repair of the peroneal tendons, if they are less than 50%, so direct repair, just use an absorbable suture and repair them. If it's a severe tear, more than 50%, or the tendon degenerated, this is the time you need to either tenodese the brevis to longus or longus to brevis, or even to borrow another tendon to do the job like the FHL. Definitely, you have to treat the underlying condition, especially the lateral ligament instability, the bis cavus, and calcaneal fracture. As you can see, it's direct tendon repair. As you can see on the left side, you can see here we do a tenodesis because this part of a vascular part isn't doing the job. So Redfern and Merson in 2004 has made an algorithm for the treatment of this. They found that the only way to know the actual tear in the peroneal tendon is intraoperative. So if you open the peroneal tendons and you found that one tendon is injured and the other tendon is okay without any problem, so you have the option either to repair the tendon excise the slit and tubularize the tendon. If the tendon one is torn and the other is the other one is usable, so this is the time you can tenu these one to the other. If both tendons are gone, then at that time you have to test the proximal muscle. If the proximal muscle is still it has some exertion still going, there's a tendon, you can use a tendon graft or a cable. If there is no exertion in the muscle, in the proximal muscle, and there is a lot of scarring, this is the time you have to get a tendon transfer. So calcaneal fracture is one, firstly, the lateral ligament reconstruction. So you have to repair the lateral ligament reconstruction if you have to do a lateral ligament reconstruction if you have a lateral ligament injury, because with lateral ligament injury and ankle instability, all the stress will go to the peroneal tendon. So your problem will never be sorted even if you repair the peroneal tendons. So you need to treat the underlying problem. Like if you have lateral ankle instability, you have to do a lateral leg repair with Prostom Gold. If you have a cavus correction, again, you have to correct the deformity. Otherwise, there will be a continuous stress over the lateral aspect of the ankle. So you need to do your shifting osteotomy for the calcaneum, and you need to do dorsiflexing osteotomy at the base of first. Calcaneal fracture is one of the commonest causes to have a subfibular impingement, because with broad calcaneum, there is no space for the peroneal tendons to run, and the hypovascular or the zone of avascularity is more and more avascular. So the peroneal tendons are very prone to have problems, especially tenosynovitis and tears. So you have to treat this doing an osteotomy. You have to do some correction. At least you have to do debulking of the lateral gutter. So give the peroneal tendon a space to run. With severe bisplanus, the same problem. So you have the ankle or the heel in severe valgus. The subtalar is very athletic and heel in severe valgus. And still the problem of subfibular impingement, which needs correction. Otherwise, the peroneal tendons will be under continuous stress. So what I do? So basically, I don't take lateral ligament, lateral ankle pain slightly or lightly. I go through very thorough history and examination, looking into the patient symptoms. I check if the patient symptoms are mechanical symptom or just pain, and if this pain came after an injury or trauma or just is accidentally started, how this pain is going, where is exactly the pain and tenderness, how is the alignment of the foot, if the foot is in varus or in valgus, has the patient has any previous injury to the ankle, like an ankle, have some sort of ankle instability or ankle sprain. I examine the patient, I see the patient walking, I see the patient standing, I see the patient on the couch, and I'm looking into any malalignment, I'm looking into any obvious dislocation or subluxation, and I put my hand there and check where is the tenderness exactly. Is the tenderness across the tendon, along the anatomical course of the tendon? Is the pain at the peroneal tubercle? Is the pain at the cuboid groove? If the patient has any evidence of os peronei or not. My investigation is if I suspect subluxation or dislocation, especially intersheathal subluxation, I go for dynamic ultrasound. But the problem, it is very operator dependent. If not, MRI scan will be my first choice. All treatment will start with non-operative try. So I will give the non-operative a try, get the patient resting in a boot or plaster according to the degree of pain and injury. If tenosynovitis and small tears, this patient will definitely get some benefit and the symptoms will be relieved. If not, and it's a bigger tear, so the option is to go and repair it. If it's unrepairable or it's the tendon is degenerated, this is the time I need either to do a tenodesis to one of the tendons to the other, or to do a tendon transfer. If there is subluxation or dislocation, so I will go with the evidence doing an operative stabilization of the superior peroneal retinaculum with groove deepening, and I'm deepening my grooves always with a pair. So then if there is any malalignment, if there is any lateral ankle instability, I address them at the same time. Thank you so much.
Thank you so much.
Thank you
دكتور
دكتور محمد
محمد.
هاشم.
اتفضل يا فندم.
اتفضل يا فندم.
اتفضل يا محمود. اتفضل.
Thank you, Dr. Muhammad Hashim, for this interesting talk. Now we can leave lateral ankle side pain lightly. Thank you, Dr. Muhammad Hashim.
Anytime. Thanks.
Any questions?
دكتور محمد كنت منور باريس يا دكتور محمد.
ربنا يخليك يا فندم، الله يكرم حضرتك.
الله يخليك يا فندم. هو I think the last speaker will not be able to be with us, Dr. Karim Mahmoud from USA. لانهم عندهم وقت صلاه الجمعه دلوقتي. هو انا معاه بس هو up till now ما خلصوش الصلاه. But I think he will not be with us. If we have any questions to Dr. Muhammad.
Sure.
Our colleagues, any questions?
Okay.
Thank you, sir.
Now we come to the end. I would like to thank all our eminent guest speakers. Many thanks to all speakers from Egypt, from UK, from India, from USA, although he's not able to be with us. Many thanks to my dear brother, Dr. Mahmoud Abu Zaid, for being the moderator of this session. We will be with you 1 month from now in the shoulder specialty day. So I would like to thank all of you and hoping to see you soon, inshallah. Thank you so much.
Thank you, Professor Ashab.
شكرا
Thank you, Professor Ashab.
شاكرين يا
Thank
فندم.
you.
Thanks.
جزاكم الله خير. تصبحوا على خير يا فندم.